All right, you will notice I'm using a microphone.
Sounds good.
So these are our microphones today. So when you speak, you must pick up your microphone. And on the side of your microphone is a button, and you must turn it on. And you must remember to turn it off before you put your microphone down. Otherwise, we will hear you put your microphone down.
Oh, mic drop.
Drop the mic.
Yes,
Yeah.
exactly. Unless you're trying to make a
Sounds
statement.
Really important.
I don't know if I can do that.
All right, so everybody got that? Okay. So Zeke and Brenda are not able to attend today, and I think Rosinda is going to be attending by phone. So the first thing we have are the minutes. And so I noticed, as much as I wanted to be at the Yellowhawk tribal meeting, I was not. And so I did not do the welcome and call to order. I believe that was David, so we just need to make that correction. But I was there in spirit, so I appreciate acknowledgement of that. So any other changes or corrections to the minutes? Hearing none, we will assume they are approved. Okay, so moving right along, we'll have the liaison updates. Your digest is included in your packets. Kirsten, do you have anything for High Talk?
I just.
Remember to use your mic.
Oh, thank you.
High Talk's doing some great work. I enjoy being the liaison. And there's a great summary in our packet here. I will just add that there are a few updates after our last meeting last week. On the social determinants of health update, it talks about a community information exchange, which I think is a really exciting effort happening with HIT Commons. And I think the one update is that it does look like a kind of single platform for statewide information exchange is not quite feasible at this point, so they are going to roll with a phase one in the Portland area because there's a lot more interest and willingness to get that off the ground first. And then convene a stakeholder process for how that might happen statewide. So I think that's a really exciting effort, connecting people to services that they need and expanding our notion of health. So. And I also just wanted to flag this provider directory. I think the update in here is great, but that there is this exploration about creating a provider directory that it wouldn't be accessible to the public or patients, but for providers to connect with providers, insurers, CCOs, hospitals, and payers to connect with up-to-date information on all providers across the state on a single platform sounds like a great effort in terms of making it easier for both users and contributors. So. John?
If I could just ask, why wouldn't it be available to the public? I mean, I should tell you, the most difficult thing for anybody who wants to do anything involving providers is getting their name and address right. It seems bizarre that, you know, the name and address of healthcare folks who are in the business of taking care of people isn't public and easily available. Seems bizarre.
Agreed, and I think as did several members of the High Talk committee agree with that and asked about it, and I think this is how it will start, and then I think we should keep asking that question.
There's going to be a significant debate about health information. All of the stuff that's going on around interoperability that's coming out of ONC and HHS. These new apps are coming. So this is just the start, and I hope Oregon is, you know, at the leading edge of that.
Yeah, I mean, I'd just say that, so it's more than exploring provider directory, and we're close to launching it actually. So it's underway in terms of development, and I think Kirsten's right in terms of starting slow, building additional uses for it. We're even thinking about things like how can it fit into the benchmark. So I think there's lots of potential future uses once we have it stood up. And I think, John, your point's well taken in terms of future work. I know Susan's team's keeping a close eye on what's coming out of ONC and thinking about strategic planning in terms of future health IT work.
Thank you. David, do you have any
Yes.
updates?
The Public Health Advisory Board continues to be innovative and thinking out of the box. And in the last meeting, I think was a great example where recognizing that more than half of our health status occurs where we live, work, and play, and outside the health system. The Public Health Advisory Board met with the Oregon Transportation Commission to look at statewide health disparities with respect to transportation. And I think it's a great discussion. It's a great start of a discussion that will continue. I pointed out for us because I think I'm really proud of the work we did with CCO 2.0, and there's important work to do in terms of implementation. But I hope once we get to implementation behind us, that we can then start to partner with other parts of the state outside the healthcare system, specifically the criminal justice system, the foster care system, transportation, the school system, because I think that's where the leverage really is in terms of advancing health equity. So yay for the Public Health Advisory Board. With that.
Thank you, David. Rosinda, are you on the phone yet? All right. Jeremy, they have you listed for metrics on scoring?
That's right. So I think in your packet, we're going to have a discussion later about the letter to HPQMC, but in your packet should be two documents. One, I'm looking at Jeff, or did we put it in the...
Yeah, it should be the end of the liaison.
This one.
There you go, perfect. Yes, so in your packet, you've got this document that shows the final metrics that were selected for year 2020, as well as the retired metrics. And a couple of key notes here. I think as folks remember, the governor wrote a letter to Metrics and Scoring Committee, really directing them to consider making sure that they were picking more innovative metrics, that they're really setting up CCOs and providers for success through the metrics that they select. I should say success in terms of meeting the CCO 2.0 goals and really rallying focus around those areas. There's been a lot of discussion around whether what was 19 metrics in 2019 was too many. I think we're seeing that CCOs are still overall continuing to improve. With a 2018 report came out last week, we saw 3 CCOs that didn't meet all of their metrics, and we know we keep raising the bar, and as we raise the bar, focus becomes more and more important. And so the committee decided to slim down the number of metrics to 13, but selected a number of the more transformative metrics that they have within their list that's available to them in terms of children's health, behavioral health, prevention, oral health. So I'd call your attention specifically to the continuation of assessments for foster youth, immunizations and smoking cessation, depression screenings and SBIRT screening, as well as oral health. So those were sort of 4 areas that we had highlighted for metrics and scoring that we were really hoping they would take up and they would focus on. Really important in terms of meeting the CCO 2.0 goals, and they ultimately did select those.
Carla?
John?
So this was a really interesting meeting. It's one of the most interesting meetings I've ever been to in my 40 years. Clearly, the governor's message was heard. The health authority's message was heard, which is fantastic. Clearly, the members of this committee have been lobbied significantly, extensively, all of them, by CCOs and by other parties. The general message being, and multiple of them said this, we want fewer measures, but we want these measures. And not agreement among the various parties. There was a lot of submitted testimony, especially by pediatricians and folks who took care of kids. So I was impressed with the process because it's good to get that kind of input. But, you know, I think when you look at which measures were retired, we have an obligation to keep track of those. And OHA repeatedly said those are going to continue to be measured. They're not incented. Because I think there's 3 or 4 in particular that I'd bring to your attention. The incentives around PCPCH were eliminated. The logic of that, I think, was, well, in other ways, the state is going to incent the primary care model and primary care transformation. And I personally would love to know, and I think there's other primary care folks who would love to have a more explicit explanation of what has replaced that, because there's a lot of us who think that's really important. I was surprised that adolescent WellCare visits were eliminated, because I think the sense was they topped off at around 60%. Adolescents include people 18, 19, I think even 20 years old. Those folks are hard to keep track of. But I think you have to ask, well, wait a minute, when we say we're topping off at 60%, we're saying that's it. That used to be a measure when I first came on here. We were very proud of it, because it had gone like this and then went like that. The other two that I think and I'm not talking about immediately, but some longer term soul searching are needed, is colorectal cancer screening and hypertension. Again, in both cases, I think the rationale was these are topped off. I mean, colon cancer screening, again, is at 60%. You know, does the Oregon chapter of the American Cancer Society think the best we can do is 60%? And I was at a national meeting where advocates for hypertension were very outspoken about the need to, you know, remain focused on that disease. And now remember, both of those diseases, we know that African Americans, there's significant disparities. So even though it's 60% for the population, it's probably not that for African Americans. And even though it may be 90% for hypertension, it's probably not anywhere near that for African Americans. So, you know, it would make, I think it would be good to talk at some point about the state should especially focus and communicate to the public, and especially to the advocacy groups for these measures, what is happening every year since they've been, you know, taken off the incentives. I heard this morning, and this is a tough job, and I think those committee members deserve a lot of credit. If you think you have moral clarity, you probably just haven't gotten deep enough. And I think that's you know, kind of the case here.
I'll just say that we do, for retired measures, track and put those out as part of every year's incentive report. So this last week, the 2018 report just came out. It reported the current incentive metrics for 2018, a whole series of other metrics that aren't part of the incentive program, but that we measure for CMS or for other purposes, as well as recently retired metrics.
Are they reported by CCO?
Yes.
Yeah.
And then I'll just say that there is a great one-pager that the staff put together of sort of what the interplay is between metrics and scoring and Health Plan Quality Metrics Committee and what their overall timeline is, that I think just wanted to be a reference for you all. I think we're all still, it's a relatively new process having Health Plan Quality Metrics Committee on here, and our team put together this one-pager to try to describe how the two work together and the overall timeline. And I think we've said this before, but just a refresher. So the Health Plan Quality Metrics Committee, at beginning in January, is appointed by the Policy Board. Their role is really setting metrics across, they're designed for across markets, and it's a menu set for different markets to pull from. Metrics and scoring by statute is, it has designated seats. It's appointed by the OHA director. And ultimately, they are the ones that make the final decision in terms of metrics for the CCO Quality Incentive Program. But anyway, just wanting to have this one pager. That's my update.
Okay, so I think this is a good segue into the guidance letter. So that is in your packet also. And we have sent this out. I think there's been 2 drafts that have been sent out to you and have solicited comments. And so I wanted to bring this before you one last time. If there's no changes to it, then I will sign it after the meeting. My hope is I'll be able to attend the meeting in September to be able to discuss this with the committee. So this provides clear guidance, we hope, to the HPQMC. The guidance is from the board and is in alignment with the governor's priorities. Specific guidance includes to develop a specific process and criteria to consider measures which align with these priorities, such as health equity and value-based payment, and include a measure of health equity at the next opportunity. And John, I appreciate your comments that you made about the health equity discrepancies perhaps in these different disease processes, and certainly that might be something that the committee could explore in relationship to this guidance. There's direction to OHA to improve demographic data. We've talked about that quite a bit at the board level. And guidance to produce a core measure set that can be used by all health plans across Oregon. So this is your opportunity to give last minute thoughts, comments, changes before I sign it. Okay. All right. Do we need a vote? Do we actually need a vote? Okay. No. All right. Great. So with that, I'm going to check one more time to see if Rosinda's on the phone.
She's not yet.
Okay.
We did hear from her that she said she would call in if she can, and we'll confirm this product order.
Okay.
Carla, just one thing I thought could be a little confusing. The core set that's called for here is obviously not the incented set.
Right.
And so everybody, I think, should just understand that. So there could be measures in the core set that aren't incented.
Correct. Okay. Jeremy, you're back on again.
Well, this will be quick. So Pat was unavailable today. He's at the National Conference of State Legislatures. I'm not sure which one it is. And the 2 main things I would give you an update on are CCO 2.0 and the legislative session, but we have both of those on the agenda. So I will probably pass on my update today, but happy to answer any questions if folks have burning questions about what's been going on.
With that, do you want to talk to CCO?
All right. Well ahead of schedule. In your, this is going to be interesting, holding the microphone. I do feel like I'm singing karaoke or something.
Yes. That's the viral video.
That's the goal. In your packets, you have a pretty lengthy CCO 2.0 slide deck. We slimmed that down, so what I'm going to go through today is an abbreviated version of it, but you have the longer one in your deck, which has a few more details. It's largely pulled from a 6-hour kickoff meeting that we did with CCO leadership about a month ago. So it's 6 hours worth of material, which I'm not going to go through today. But I'm going to try to hit on some of the main bodies of work. There's been a substantial amount of work that has been going on through the last year. Obviously, you know about the evaluation process, but there's a number of other work streams that have been going, that have been moving forward as we've been going through the evaluation process, from member transition to contract and rule review. So I'm going to give you kind of a highlight of some of those main bodies of work, and happy to answer questions as we go along here. So the main areas I'll touch on: service area and awards, member transition. I'll spend most of my time on those 2, as well as readiness review, and then we'll just hit lightly on the work we've got underway for rules, contract changes, and rates. So first, let me run through a few key dates. And let me just say at the outset that one thing that I don't think that you had heard until now is that we're basically going to have 2 opportunities for members to choose between CCOs in parts of the state where there's multiple CCOs. There's about 400,000 members that we think will be part of this in a part of the state that has more than one CCO that they could choose from. I'll talk a little bit more later in the presentation about some more of the details of what that transition is going to look like. But this timeline will show you sort of the overall flow, and then we'll go into, there's some other iterations of this throughout the slide deck. But in August, we're doing a series of rules advisory committees for updating rules to align with CCO 2.0 goals and the board's recommendations. We'll be going through a readiness review process in August and September. Then in September, the member communication begins, starting with a postcard to members, starting to let them know that there's a opportunity for changing CCOs coming up. September 30th is the date that we're aiming for signing the final contracts, and then they will go to CMS for final approval. In October, we will sort of kick off the first opportunity for CCOs to choose between CCOs. That will start with a letter going to members in areas that are impacted by or have an opportunity for choice between 2 CCOs. They'll have about a month for that first opportunity, and then we have to hit sort of a data pause between then and the end of the year, so that CCOs can basically get member packets out, things of that nature, from the 17th to the end of the year. For folks who wanted to choose or have something going on, it'll be more of a close coordination between OHA and the CCOs until they can get to the next opportunity, which will begin in January 1. There'll be basically another 90-day, in essence, open enrollment period. We're calling it member choice, so it's not to be confused with the open enrollment period that's somewhat overlapping with this for the marketplace. So there'll be basically two opportunities for members to choose, and happy to answer questions now, but we'll also be covering this later too.
And are members locked in for the next 5 years, or do they have an annual open enrollment thereafter?
They can change once a year.
Once a year.
So there's not a normal sort of open enrollment period, but our rules allow a member to call and change a CCO at any point once a year. This is the overall, very slimmed down, sort of high level timeline, as you can see, between basically July and the end of the year, recognizing that this will actually goes on into next year quite a ways, but you can see there's a number of workflows happening here, from awards to rate discussions, contract discussions, rules, updates, the member transition period, a readiness review period. So I'll cover some of these in more detail, but they're in essence a number of connected but independent work streams with a lot of folks involved. So let me cover first service area and award review. The way the evaluation process worked is there were teams set up in 6, basically organized in around 6 categories, and you'll see that these aren't aligned with the CCO 2.0 goals. Those were sort of embedded in each one of these, but the applications were reviewed based on subject matter experts in these 6 areas: care coordination and integration, delivery system transformation, community engagement, clinical and service delivery, business administration, and finance. In addition, there was a financial viability review that was done for each of the CCOs. All of the applications, to the extent there's some redacted information, but for the most part, the applications, summaries of the evaluation are now posted online and available. I'm happy to answer questions if folks have this in here. I didn't plan to go through applicant by applicant, but if you're interested in kind of how folks did or some of the notes or comments from the evaluation process, we have all those available online for each of the applicants. Online, here's the website where we've got everything posted. As I mentioned, we've got a summary of award decisions. We've got maps showing the awardees by county. We've got an updated draft contract available, updated rules. Just this last week, we also posted deficiency letters for every CCO. So even those who were awarded 5-year contracts had areas where they didn't fully meet our application expectations, and so every CCO was sent a letter outlining where we wanted to see some improvement and basically asking them to go back and shore up those areas of their application. We had 19 folks, 19 organizations that originally applied. 15 were ultimately awarded, covering every part of the state. Several parts of the state, as I mentioned, will have more than one CCO. The southern area, Southern Oregon, Jackson County area and South Coast will continue to have more than one CCO. Lane County area will have more than one CCO, and the Portland area will again have more than one CCO. There were 4 organizations that were not awarded a contract. That was Motive for the Salem area, Motive for the Lane County area, as well as for the North Coast, as well as there was a Willamette Valley Community Health was the Salem area, Marion Polk County area CCO. They did not reapply. An organization, some of the organizations that were part of Willamette Valley submitted an application under a new name that was not awarded, and then Primary Health, which is an existing CCO, was not awarded a contract. So there'll be basically two organizations that will be winding down. Willamette Valley, like I said, who decided not to reapply, and then Primary Health, who was not awarded a contract.
So Jeremy, the decision to add CCOs into certain areas, what drove that decision? Was it felt like the need for competition, or that there was a lack of capacity in the existing CCO? Was there a thought process behind that?
It really goes back to conversations we had, well over a year ago around whether this was going to be a request for proposals process or a request for applications process. Under a request for proposals process, which is sort of the standard way that the state does procurement, you solicit bids, you score those, and you pick however many you want. You pick your top 1, you pick your top 5. You sort of have a predetermined number of organizations that you're going to select on the outset, and then you do that based on score. We did a request for application process in 2012, which is a little different. That's a process where you set out expectations. You don't predetermine the number of CCOs going in, which means in essence that anybody that makes it over the hurdles basically is awarded a contract. So we'd evaluated both of those and discussed it with the board last year, and decided that we were going to move forward with the request for applications process. Because of the benefits of sort of the community coming together, be able to put together the application, not predetermining the number of CCOs on the outset. It seemed that was more aligned with the overall vision of CCO. So that decision basically dictated whether or not there would potentially be more than one CCO in an area based on whether one or more organizations applied and whether they met the criteria. The only caveat to that was really consideration of sort of financial sustainability of whether there was enough members to sustain CCOs in those parts of the state that have more than one. But otherwise, we sort of have said at the outset that there's no predetermined number of CCOs, and that means that there's the potential that you have parts of the state that have more than one.
Could you just expand a little bit on the areas that, I think there's a couple of areas where you felt only one is the best choice? Was it in Clatsop and you had, I think, a couple areas where you had a couple of applications and only chose one, and the language, as I recall, was you thought that there was only enough business for one organization to thrive.
Yeah, let me go back. So you're right. There was 2 applicants for the North Coast area. Let me go back and look at that. I think there was more than just the financial viability, but I need to double check on our evaluation criteria. For the other parts of the state where there was multiple, it was because the application wasn't sufficient in a number of areas.
Right.
Of those 15 organizations, 11 were awarded a 5-year contract, 4 were awarded a 1-year contract. And the issue here is that these 4 organizations, there were significant deficiencies in their application. likely leading to the spot where they would have been actually been awarded a contract. However, there were all parts of the state where there would be no CCO if we didn't award a contract in one way or another. So we somewhat has been making up this process as we were going along. We weren't expecting to be in this situation, but ultimately decided to do 1-year contracts for those four CCOs. We'll be working with them on basically an action plan to remedy their application and fill in those deficiencies. So there'll be a remediation plan that we'll be working through with them. They will need to demonstrate that they can ultimately meet all of those CCO 2.0 goals that we would expect of a 5-year applicant. And if they can demonstrate that, we will award them the remaining 4 years. If they can't, then we'll need to go into a plan B next year and think about what would we do to fill that area. I'm trying to think if we had more on the remediation plans here. As I mentioned, each of the applicants has received a deficiency letter within the last couple of weeks outlining the areas where we've seen deficiencies. We'll be working with each of the CCOs for how they're going to remedy that. The 4 that have 1-year contracts is, I'd say, a bit more of a escalated or expedited timeline in terms of we're going to be working with them very closely over the next several weeks and months to be basically putting together remediation plans for how they expect to remediate the deficiencies they had in their contracts. Then we'll be needing to measure that throughout the next year, and they'll need to take pretty quick action over the next 6 months to 9 months, because we'll need to figure out what a plan B is pretty close, mid-year next year, if it doesn't look like they're going to be on track to be awarded a 5-year contract. So right now we're given some specific attention to those 4 1-year awardees, recognizing we've got some real pressing time issues we've got to need to work through. That includes OHA leaders are going out starting this week to meet with them one-on-one. So Dave Baden, our Chief Financial Officer, Lori Corner, our Medicaid Director, and others we're down in Roseburg and Grants Pass yesterday. They'll be meeting with Cascade in Yamhill, I think in the next week. That's sort of the kickoff process to start talking through with them where we saw deficiencies. And then over the next month or so, we'll start working with them on developing a remediation plan for how they expect to shore up their contracts. And then we'll need to go into providing technical assistance and measuring and making sure that they're hitting the milestones that they've agreed to. But like I said, we're going to be going through a similar process with all 15 applicants. We've just got sort of an immediate need with those 4 that were only received a 1-year contract. This is the map for how things shook out. The areas of the state that have lines through, and those are the places where there's more than one CCO. I think as everybody knows, there was more than one CCO in the Portland area for the first 5-6 years. There's been more than one in the Southern Oregon for the last 7 years. So Lane County is really the only place where there's for the first time more than one. There were some changes kind of around the edges, around some of zip codes that were close to some county lines. So there's some kind of micro changes on here that don't necessarily appear, but overall, this is how things look. So any questions before I move into member transition? Our key values going into this member transition are minimal disruption, creating a process for members to have member choice and have that opportunity to choose which CCO they want to be in, and to the extent possible have a smooth and seamless process. And we're taking this really seriously. We've got teams stood up that are working day in and day out on this. I will say, with all of that said, we're trying to come up with every contingency we can think of for things that could go wrong and how we could try to avoid disruption on the outset. At the end of the day, this is going to be a huge transition. 400,000 people will ultimately have a choice between CCOs, and there's no doubt that even if we get this 99% right, that 1% is still a lot of people. And so we're doing everything we can to try to head off the disruption, but we're also preparing that and trying to prepare partners for the fact that this will be somewhat of a chaotic period over the next year as folks are trying to navigate, potentially trying to choose between new CCOs.
Jeremy?
Yeah.
Is that a function of the CCOs, or is that a function of OHA to like kind of manage the member transition?
I'd say it's both. As you'll see, there's definitely large parts of this that we're handling. For instance, there's some rules around what CCOs can and cannot, federal rules around how they can and cannot communicate with members. So we're taking a lot of that communication. But we also are expecting CCOs to work hand in glove with us, to work hand in glove with an exiting CCO or another CCO in the area to make sure that we have as smooth a transition as possible. So that includes, be able to have medical directors talking to one another, creating, case plans or transition plans as needed. So, we all need to work together on this.
Jeremy, what were the top lessons learned in the family care transition that are applicable to this current transition?
Yeah. So just on the outset, I wasn't involved personally in that, but there were a number of lessons learned. I think there's things like some special populations that were identified that weren't necessarily identified at the outset, that ended up being some specific populations that we needed to have a higher level of focus on. So transgender individuals is one that's come up. So there are a number of lessons. Thinking about covering providers potentially who are out of network for a period of time as a potential remediation. So so there are a number of lessons that we've been trying to work into this process.
I mean, my guess is the major issue is going to be, is my clinician? Where's my clinician? And it gets back to, the public doesn't even have access to a directory of who the clinicians are in the state. But I would guess it would help if clinicians took a proactive approach to identifying which of these CCOs they were in or not in. As part of another project, I visited many of the websites of primary care groups, and some of them are great, and some of them are way out of date. And I think that's going to be a major piece.
Yeah. So you'll see here we've got totally agree, and we're doing some specific communication and outreach with providers, provider organizations like the Oregon Primary Care Association, Oregon Medical Association, others. There's a couple of things that we know from the outset. We've scoured all the other states that have gone through this over the last 5 or 10 years, have talked with them, understood their experiences. They've all handled this slightly differently in terms of member choice. But there's a couple of things that we know, and that is, one, very few members will actually proactively select a CCO, just given the choice. The highest that we've seen from some states is 30%, and some states have said as low as 10%. Where the rubber meets the road is when members get in to actually see the provider, and then they realize they're out of network, and then they want to make a switch. So that's part of the reason that we're doing the double choice period, recognizing that it may not be until next year when they actually go see their provider that they realize that there's been a change and that then they want to make the switch, but want to offer that opportunity ahead of time if they feel like they're not in the right CCO. The other thing that we're doing is we're proactively matching members to a CCO based on their primary care provider and based on their behavioral health provider. So the letter they will receive in November is, this is the CCO we've matched you to. For those members that don't have any recent experience, there's a basic random algorithm that will be used. So the letter is basically saying, this is who you will be transitioning to. If you don't want to make that choice, if you'd rather pick another CCO, you have till November 17th to let us know. And you'll have another choice, you'll have another opportunity beginning in January. So we're trying to proactively make that match ahead of time, while still giving members the opportunity to make a choice on their own.
So the assumption is that the person, the care providers they've been seeing, the healthcare providers, have contracts with both CCOs?
No, we'll be doing it based off of which CCO has a contract with that particular provider.
Okay.
So we're looking at experience of who the member has been seen in terms of primary care provider and behavioral health provider in the last year, then looking to see which CCO has a contract with them. If only one CCO has a contract with them, we'll map them to that CCO. If both CCOs have a contract with them, then I think it's just it'll be a random assignment.
So you're not going to change their healthcare provider?
We're trying as hard as possible to preserve continuity care at the primary care and behavioral health provider. And that was based off of a lot of feedback we received from a public hearing back in November, where we outlined several options to do this. And overwhelmingly, the feedback we got was prioritize relationships with primary care and behavioral health providers.
Just a quick follow-up question into that. Maybe I'm getting too much into the weeds. So for example, like Trillium, who's going to be now providing services in the metro area, and then you have folks already who are matched with a current provider. So and now it sounds like that would be more of a random sort of placement, or are they going to be sort of be split so that both CCOs are financially viable? How does that work on that side?
Yeah, we basically have, our system has an existing algorithm for random assignment when somebody doesn't make a choice. So if only one CCO, so there's a series of actual steps it goes through. So if it looks at pre-existing relationship with the CCO, we'll be pausing that for now, but that also looks at what other family members are in the CCO, and we'll be adding this criteria around looking at whether the primary care behavioral health provider is in the CCO. So it's not a half-half split. There's actually a number of there's a rule, you go through a number of decision points to figure out which CCO member goes through. You know, look first at that primary care behavioral health relationship, then we'll look at whether there's family members in a particular CCO. Then you kind of, when you get to the very end of the line, then it's basically a random assignment from there. So it's not going to be a 50-50 split. Members will be assigned based on that criteria, and then whoever's sort of left will be a total random assignment.
Just to follow up on that though, is there kind of a minimum number of members to each CCO that is needed to make them both financially viable though?
Yes, so they basically submitted pro formas, but expecting, start outlining their financial performance. So yeah, after the end of this, then we need to go back and see if they actually got the members that will allow them to be viable, or maybe they didn't feel like they got enough members. So there's that risk at the end of the day.
Good luck.
Yeah, and I should say that this we'll be in this for a full another year at this point, because we'll have the member choice period for the first 90 days. So we won't fully know how things shake out until the end of that. Then we'll go back and do a risk adjustment on rates based off of the final membership profile next summer. So it will be next August before we've sort of finally gone through the transition of this into CCO 2.0. If we do all of this right, and these are our goals, is that members will know what choices are available to them. They'll understand that their OHP benefits are not changing. And I should say, this is based off of focus groups that we did, or our communications team did over the last couple of months with a number of members to try to understand what was most important for them. And the feedback we got overwhelmingly was basically, if nothing's changing for me, don't communicate with me. If I get a letter in the mail and I don't really have a choice between CCOs, that's just gonna freak me out that something's changing. And really emphasize that the benefits are not changing for members. So based on the focus group feedback we got, this is sort of our criteria for if we're successful, what this will look like. Members will understand the choice, they'll understand that their benefits aren't changing, they'll know how to compare CCOs, and we're developing a comparison chart for members to be able to use. They'll understand what tools are available to them for being able to make a choice. We're providing an online tool for folks to be able to go in and make that choice themselves. They'll know where to go get help. We're actually contracting with a separate call center to add capacity specifically for this member choice period. They'll not be stressed about the change, and they'll feel respected and valued.
What happens to the fee-for-service folks? Like the fee-for-service folks that are in a county where there's now 2 CCOs?
So by law, it's mandatory enrollment into a CCO unless there's an exception. So those exceptions include folks who may have a real specific medical condition or care plan that makes fee-for-service a better situation for their particular circumstance. Tribal members always have the option to opt in as opposed to opt out. Dual eligibles always have the opportunity to be in fee-for-service. That was always an opt-in. We've moved it to an opt-out, but they have the right to opt out. So if somebody's in fee-for-service now, it's because they've already met one of those exceptions. So we aren't planning to disrupt that. This is really going to be for those members that, the other basically 90% of members that should be enrolled in a CCO.
So this won't be an opportunity for them to reevaluate their decision?
They always have that opportunity.
Okay.
To that point of, don't send me a letter if you don't have to feedback that we received, we're, at this point, I don't believe, planning to communicate with them directly during this period. So we'll be doing both direct and indirect communication, including mailers, postcards, letters, direct phone and text and email outreach. As I mentioned, we're getting a contractor on board to help us with that. There'll be a lot of indirect communication to try to create some just awareness in the communication, things like earned and paid media and social media. The overall timeline looks like this. So in early September, we'll launch the CCO 2.0 Member Choice Specific Call Center, and all our communications regarding this choice period will have a designated phone number, so folks go straight there as opposed to the separate DHS call center, which those folks will be well aware of what's going on, and we'll be able to handle folks if they call in, but we're trying to get people directed to one phone, one place for member choice. We'll be getting to raise awareness through postcards, web content, things of that nature, beginning in September as well. Mid-October, members will receive, first they're going to receive a postcard letting them know that there's a choice period coming up. Then they'll receive the letter of that initial matching. They'll have until mid-November, and we'll be doing robocalls and texts and a number of other things in that period, again, to just create awareness. There'll be that sort of freeze period from November 17th to the end of December, but we'll be staffing up for any care coordination that we need to do, working with individual CCOs for instance, if somebody suddenly has surgery scheduled for January 8th, we won't be able to change their CCO, so what we need to do is really develop a care plan to make sure that their care is not disrupted in that period. And then in mid-December, CCOs will receive their final list of members. We'll start sending new welcome letters to new members, and then a new choice period will begin in January. I think I've gone through most of this, what's going to be in the letter in October. And then we'll also be ramping up provider communication as well. And as I mentioned, we'll be working with a number of partner organizations to try to create awareness among providers that this is happening. Our expectations as CCOs, and this gets to Oscar's point around sort of who's responsible for this, and we all are. If we want this to be successful, we'll be starting to launch some medical director specific work groups to start working on how the transitions of care and care coordination need to take place from a provider perspective. But we're expecting CCOs to be active partners in this transition, and that includes doing everything they can to preserve continuity of care as members transition, working with one another to exchange data or information that's needed in order to create a smooth transition. We have some specific transition of care processes that are now established in administrative rule. And so a part of what the medical directors will start working through when they meet is exactly how that will roll out. As I mentioned, creating data share agreements or agreements with providers as needed to be able to share information, to be able to support this. Any other questions on member transition?
I see in our packets that the web form will only be in English and Spanish. Is that only the web form, and all the other communications will be in?
Yeah, I believe so. I need to double check, but I think we will be launching a web form from October to November, so members can go actually make the choice themselves. The call center folks will have access to that same form. We're trying to get everybody to use the same tool. I believe English and Spanish is all that was available, but there will be other communication. We still need to follow our ADA requirements, other language access requirements in terms of communication materials.
Yeah, I have a question too about the communication methods. From the packet, it seemed like sort of letters and postcards and some robocalls were the primary method of communication. And I think, just personally speaking, I think that would be really difficult to kind of really pay attention to just something so important. and also very complex. So the language that it comes in, how it's talked about, and also such a short timeline to make a really big change could be really difficult. And hoping to see if there's other more relational methods of talking to the members. I know it's a big group, it's a lot of folks, 400,000 people is a lot, but wanting to figure out if there's just like other complementary methods that are more about talking face to face to someone, or creating, you know, sort of like sort of pretty events where folks can come and hear more from somebody.
Yes, that was not an exhaustive list. So we also have application assisters right now, community organizations. We'll be working with them, utilizing them, community partners. So we'll be using all those other sort of forums or ways that we can communicate with folks. I mean, it's really an all hands on deck. So we're trying to think through every sort of avenue that people want to get communication. And we're also, we had some really focus groups that we're now going back and doing some you know, touch bases with other organizations as we're trying to compile materials and get feedback and make sure that we're trying to make this communication as user-friendly as possible. But I think those are really good points. Happy to take that back, and if you have other ideas, we're happy to feed that into our process. Okay, so then readiness review. So readiness review will be happening in essence between now and the end of September. It's a federally required review of certain, making sure that the organization meets certain federal requirements. This is not a check the box sort of exercise that we're going through. There are some specific things that we have to look for under federal law, but we're using this as really a validation process to make sure CCOs really are ready to go on the CCO 2.0 goals that they've outlined in their application. So there's a couple of areas specifically that we know that we'll be doing some deep dives into. One is around community engagement, community partnerships. They all were evaluated on that and had to describe their partnerships in their application, but we'll be going through a process to sort of test that. Provider networks is another one. We get their provider network reports that basically outline the providers. We'll be going through a process of actually validating that, probably a sampling process. So readiness review is a real thing. It's possible that somebody comes out on the other end of this, not with a contract, if it turns out that we get in there and find out that there's some significant problems. But it's really designed to ensure that they meet they're ready to go, that they meet the federal and state requirements, that what we evaluated them on is they can show they're actually ready for success in those areas. We will be prioritizing. We obviously aren't going to build prioritize every piece of the application or every part of our CCO 2.0 goals. So we're going through sort of a priority process of how we're going to evaluate folks in readiness review. And the highest priority is given to issues that directly impact a member's ability to access services. So the biggest thing we want to make sure is that coming out of this, the CCO is ready to start taking members in December, in essence, and that they've got those provider networks stood up, they've got the relationships needed. For other things that don't directly impact a member immediately, they'll be moved to sort of a medium priority, corrective action plans created if it feels like they can get there with some work. But if they just aren't ready to accept members, this is the time that we need to figure that out, and that they may have to make some hard choices at that point. The overall timeline, as I mentioned, basically started in August 1 with some data submission. We have a third-party contractor that we're using that goes out and actually does some desk reviews, desk audits, is actually out working with each of the CCOs as part of this readiness review process. There'll be, for any concerns that are not so serious that they can't be remedied, there'll be a phase 2 process following this where we'll be looking for what they need to be able to do to shore up those issues or remediate them, and then we'll start to move into technical assistance as we always do as part of CCOs for the Transformation Center. If there's areas where they just need some assistance in order to understand best practices, that will be sort of part of the CCO 2.0 implementation, not just in this transition, but really throughout the next 5 years. Questions on readiness review?
will these areas of corrective action or kind of audits that show kind of things need to be shore up be public?
That's a good question. I don't know. We generally have been approaching this around trying to be as transparent as we can, and I think have demonstrated that in a number of ways that that there's more information available than there certainly was in 2012 in terms of evaluation reports, deficiency letters. So I don't know the answer if there's certain proprietary things or things we couldn't make public, but generally as a principle, we've been trying to get things posted and made available as soon as we can after they come in. For the most part, things are public record when they hit us, and so rather than trying to wait for that public records request, we've been trying to get things out as quickly as we can. Okay, last two I'll just hit really briefly, and that's, or last three I guess, and that's CCO rulemaking, contract review, and rates processes. We did, from the time the applications, or the request for applications was posted in January till this summer, we've gone through and done deep dives in two areas. One was a sort of wholesale review of our administrative rules, and the other was pretty much a wholesale review of the rest of the CCO contract. So leading up to the RFA being posted in January, the focus was really around the parts of the contract that were specific to CCO 2.0. We went back and did a wholesale review of the whole thing, including kind of the base contract that existed before. And we've done a lot of trying to reconcile rules and trying to reconcile our contract. On the rules side, they were just largely, we just found a lot of places where they're largely out of date. And I'd say we also found a lot of areas where I don't think there was a clear standard around what went in contract versus what went in rule, and so you had duplication. We've gone back and sort of done a full shoring up of both of those. And things that are going in rule are primarily those things that really have impact a third party in some way, a member, another community organization. Things that are really just specific to the relationship between OHA and the CCO are going in contract. But we've got basically two lines of work that are happening at the same time, and that's on the rules piece. We're doing a rules advisory committee meetings in each of the CCO 2.0 topic areas, as well as a few other topic areas, where we're in essence making sure that our rules are clear around what we are expecting in CCO 2.0 based off of the board's priorities, right, or the board's recommendations late last year. So CCOs are involved in each one of these. I think there's 1, 2, 3, 4, 5, 6, 8, I think roughly, rules advisory committees meetings happening throughout August. You can see these are sort of organized around topic areas that align with CCO 2.0. On the contract side, we're in essence doing the same thing. Where we went back and looked at, we had outside counsel or special counsel do sort of a wholesale review, and we're really looking for making sure that all of our terms were updated, all of our links to rules or to the contract were all updated, trying to get rid of any out-of-date references. There was a lot of clarification of terms and roles and responsibilities and accountability that we cleaned up. So one of the biggest areas that I can give an example of is there was lots of reports that CCOs were required to submit. It wasn't always clear where exactly they were supposed to submit it. It wasn't always clear what the timeline was supposed to be, and we were sort of inconsistent in terms of our terms. Things like what's a work plan versus a report versus a transformation plan or something. So we went through and did sort of a wholesale review on that, making sure that anywhere in the contract where it looked like we were saying there was some stated goal, but it's not really clear what the expectations were, cleaning that up, making it clear on what reports or deliverables are due and when and where they're to report it to, and actually created a whole addendum that outlines every report and deliverable that the CCO has, which I think is good for just being clear about what's required, but I think also from a transparency standpoint. I mean, it's very easy for the public or somebody to now go and say, what are all the reports that the CCO submits? And then I think really pressure test whether we were being clear enough that we could actually hold a CCO accountable. So I think it went through a good process where we got a lot of pushback from our own attorneys to say, you've kind of got this goal, you're not being really clear about what you're actually expecting. And so we shored up a lot of that language. We've done work sessions with CCOs, or in the process of doing work sessions in these topic areas. We did behavioral health work session, a social determinants of health and health equity work session, financial reporting and cost work session, value-based payment, health IT and member relations work session. There'll be a quality and accountability work session, and then we'll do one last one, which is basically a final shore up of anything coming out of the 2019 session that requires a final change in contract. I think we've mostly identified those things, but that will be sort of the final one. So this is another kind of work stream that's been happening at the same time that we're going through the rules process.
Yeah, consistent with my earlier comments, I mean, when the smoke clears and the contracts are set and everybody knows how this is going to work, I just appreciate a summary of what incentives survived all of this process that encourages the PC-PCH model. Because the incentive's been removed on the presumption that CCO 2.0 is going to have more incentives for that, and incenting the metric is no longer needed. I think there's some folks out there that are skeptical about that, or even worried that this could create a situation where CCOs might, primary care doctors have the incentives to do it, but CCOs might not. So I think it would be good. This meeting I was at, an organization, this is a national report on investing in primary care. It's interesting data. I'll get a PDF for you all to look at. Oregon's middle of the pack, I wonder where we are, where we will be with CCO 2.0. Maybe we'll be in better shape. So,
I think John brings up a good point, and I think who's looking at these and what perspective they're looking at this can really make a difference as what is in it. So if you have attorneys looking at these, you're going to have an attorney contract, which is an important contract. But I agree with John that it would, if somebody already hasn't been looking at these from a primary care lens, or a patient lens, or a clinician lens, or because I think there's a lot of stuff in these work session topics that can support a PC-PCH model, but it has to be, those pieces have to be there. And so somebody who's familiar with that model, reviewing that, I think can help address some of those concerns, as well as other concerns that we may not have even thought about. So I'm not sure which groups are reviewing these, but.
Yeah, just to be clear, I mean, it started with attorneys reviewing to make sure, to push back to say, are we being clear enough? And a lot of, like I said, identifying where we just had out of date references in the contract, weren't clear about where deliverables were sent. But it's been the policy teams that are primarily leading this to make sure that we're still sticking to the CCO 2.0 goals that have been presenting in part of the conversations with CCO. So it has not been a sort of a handoff to attorneys. It's been a partnership. And don't say anything bad about attorneys.
I'm not.
Even though I'm recovering. So then the final step in this has been rates process. So we've also been working through final CCO rates with CCOs, and I won't go through this in great detail, but you can just see we've got a number of work groups where we're working through rates for 2020, and ultimately those will be submitted in essence alongside of the contract on October 1. Other questions?
incredible. A lot of work.
It's been busy, and this is also only, I keep remembering, this is also the only second time ever, and Dr. Sandy, you can back me up with this, that we've gone through a full procurement for managed care in the state. So I think there's a lot of lessons learned from 2012. There's a lot of lessons learned coming out of this that we'll be wanting to document for the next wave. But I think our overall takeaway is it's way more work and takes a lot more time than you ever expect on the front end.
But I think we're going to have a national reexamination of the insurance model, the insurance company model. And can insurance companies deliver on transformation? And my own sense is they'll only do that if organizations like the Oregon Health Authority hold them accountable and help them to envision the future through transformation. So I think it's incredibly important, and I'm glad to hear that it's a process that is much more than you've experienced in the past. That's the way it should be. $6 billion. Way to go.
Jeremy, for the 4 CCOs that are on the 1-year contract, what do you think is going to be the process for the Health Policy Board to be kept abreast of their progress and if they are on track to be meeting those benchmarks? Is it through the director's report on a monthly basis, or is it through a much more robust presentation on a quarterly basis? Just so that we are aware of what needs to happen and kind of in the loop about that.
I think it's a really good question, and one for maybe I think some discussion with the board at some point this fall, not just related to the 4, but actually all 15. I mean, I think one area that we've been talking a lot about internally is how do we start to build out the capacity, and it is some new capacity to be doing more ongoing evaluation of what's working and best practices throughout the 5-year period. You know, if you'll recall, we started this process last January with what we called maturity assessments, which was really trying to combine what all the data information was that we had available for the last 7 years, but that was the first time we'd sort of done that. And so how do we do that on a more regular basis and engage in the board throughout the 5 years, so we don't just sort of look away for 5 years, then come back and say, well, where are we for CCO 3.0? So I think it's a really good conversation at some point with the board in terms of what would you like to see and how do we build that as part of just, you know, ongoing work. And you know, I think it's also a question for how much time do you want to commit to this versus other things. So it'd be a good discussion at some point.
I'd really like to see all CCO retreat where we're part of that, and to have all CCOs come to the table, review the data. You know, what are the successes, what are the challenges so we can evaluate. And we've had annual retreats. I think it would be a really good topic for an annual retreat.
All right, thank you for putting us back on time. So I've been told Rosinda might be on the phone now. Rosinda, are you there?
Yes.
Okay, so if you have any questions or comments, just shout out.
Okay, thank you.
All right. Okay, so Holly is here to give us a legislative update. And I don't know if you heard the rules about the microphone.
I did not.
Okay, so you have to turn on your microphone, and when you're finished, you have to turn it off, because if you don't and you drop it, we all hear it.
Is it on? No.
Just push the button up.
Yeah, there's can you hear? No.
How come her microphone's not working?
Shannon, turn it on.
Testing.
There we go. Can you hear me? Oh,
It's you.
is it me? Can you hear me? There we go. Sorry about that. First of all, it's great to be here. I think I talked on the phone once during session to give you an update, and I believe Director Allen has been giving updates on legislative sessions since then. I'm not exactly sure how you'd like to approach this. I gave you a handout that looks at the 5 areas we were really trying to make progress in during the session. We did make great strides in all of those areas, not to say there isn't a lot more work to do, and we can go through that today. Outside of the bills that we've listed here, my team is tracking over 100 bills for implementation. So there are quite a few bills that come out of this legislature that affect health in some way. And we can continue to give you updates as you like on how we're doing with that work as we move through this interim. If you would like to continue this way, I could go through what's in the memo and then take questions as you have them. We can keep it conversational.
I just remain interested in anything related to prescription drugs, but some of which may be in the 5, but there isn't a category for that. And you know, I was on that HB 4004 or something, that interim work group that was really interesting, ended up with all these recommendations. I'd love to know which, if any of those, ended up in any kind of legislation. But this summer is great. Keep doing what you're doing.
Yeah, I think that's a really interesting topic together, and I would suggest that we come back and talk about where we are with pharmaceuticals. There were some successes. One of the pieces that did not pass that we were working closely with the legislature on was House Bill 2678 that really looked at how we, OHA, would look at pharmaceuticals for fee-for-service. And there's ongoing talk about, as well, there was another component of that that looked at how we were aligning with CCOs on a preferred drug list. And I'm looking at Jeremy because he worked very closely on that.
There were a number of pharmacy bills that were moving this session. It was somewhat hard to kind of figure out how to fit them all together. There was a couple that did not pass. There was a large bill that Senator Hayward had sponsored that didn't pass. There were a number that did pass. Happy to get you those if they aren't on the list. But the one of the only ones this session that was sort of a priority for OHA that did not pass was the aligned PDL bill. So if you recall, the policy board initially took a vote to direct us to move towards a single statewide preferred drug list. We did that analysis, found that a middle path that would basically yield the same amount of savings, but was be a little bit more nimble and with lower risk would be to just actually align or make sure we did some strategic alignment around areas where where CCOs and fee-for-service are not aligned, but where we could better maximize federal rebates if we were. The current Legislative Council's opinion has been that the current statute only allows for one statewide preferred drug list, and that we're out of compliance in essence by not having a single statewide PDL. So we had worked with Representative Noce on a bill he sponsored to try to correct that and make sure it was clear in statute that we could go this aligned preferred drug list approach. That bill ultimately did not pass, and so at this point we're going to be taking a step back and figuring out where we go from here. We're not changing the language in contract or rule that allow us to go the aligned PDL approach, but we're going to be spending the next several months sort of evaluating what do we think. Do we think that that's worth trying to take back up in February, or is there a different approach that we want to go to? So I think we'll be wanting to have those conversations with you probably a couple months out, as pharmacy keeps evolving, and so we're trying to also keep up with what other states are doing. And some other states have some new, more recent experience around the line and statewide PDLs. So I think we'll come back to you probably in a couple months when we've got a better sense of do we think it's worth trying to take this back up in February. But that bill did not pass, and there's Legislative Council believes that we should have only one statewide preferred drug list. So we'll have to come back to this at some point in the future.
And to the task force that you worked on, Senator Steiner Hayward's bill really tried to take in all of those suggestions. It seemed to have caused a flurry of opposition in almost every corner. It was a very ambitious bill. There were many good parts to that bill that we should all be thinking about and considering, but it did not seem to be the time that the legislature could really consider and pass that. Some good news. We did make significant progress in closing the Medicaid funding gap. I'm sure you're all very aware of 2010. We discussed that during session. That passed early in session. And also significant on the last day of session, in the last hours of session, we were able to pass the tobacco tax referral. So that we look forward to finding out the outcome of that in the fall of 2020. And hopefully that will pass and take care of a significant part of the gap that we were trying to close during the session. So we will continue to work on that. One that did not pass that we understand from the governor's office is likely to come back again is the employer assessment. So we'll be working closely with the governor's office to see if they want to develop that as a concept again moving forward. Do you have any questions about that area of legislative work?
I just want to add, I think folks know this, but this is really significant. We have 6 to 7 years of stability in the OHP budget that we have not ever had in my my recollection. I think the longest hospital tax extension has been 4 years, and there's been a lot of times where it's only been 2 years. And so being able to focus on how do we actually transform healthcare as opposed to how do we continue to find funding to fund it is really significant.
It's going to be an entirely new way of looking at health when we go into the 21 long session, because we're not going to be facing a $1 billion gap that we have to find a way to fill. So right away, we're going to be able to look at other problems that get set aside when you have to look at that funding gap.
And so that's at current enrollment rates?
Yes, that's right. There's the tobacco tax in particular was really important, not because of the revenue it generates this biennium, but for the revenue it generates in 21-23. That's the sort of very final pickup of reduced federal rates. There's part of the Medicaid program where match rates always go up and down, and so if we have a recession, there's some we'll have to account for. But we've had several planned step downs, and the final of those are in 21-23, and the tobacco tax in essence provides the revenue to shore those up.
But the waiver ends in 22.
That's right.
So we'll probably find out whether that's extended in 20?
July, the waiver, our current 1115 waiver expires at the end of June 2022. It's about a 2-year process to go through that, about a year of development and about a year of negotiations with CMS. So I think we'll be transitioning to start to think about the waiver when we get through the CCO 2.0 process, probably towards the end of next summer.
Any other questions about this area before we move on? Okay. The other area, I think you just spent a lot of time on CCO 2.0 and where we're headed. We did have what I would call a CCO 2.0 cleanup bill. We knew that of all of the items recommended for CCO 2.0, there were some that needed legislation. So we had an omnibus CCO 2.0 bill that really covered those technical areas. That passed, really no problem. There was bipartisan consensus. Oops, sorry, lost the microphone. We also received, and this is significant, we received financial support for CCO 2.0. We knew, in looking back at contracts, that we needed to have a more robust workforce to look at enforcement, to look at how we're actually operationalizing these contracts. And the legislature really heard that, especially in the area of behavioral health. And so they created those positions and gave us some funding for that. I think we originally asked for 30 positions. We were very grateful for, I think it was 15 positions that we did receive. Also, we were very successful in passing a financial transparency and regulation bill for the CCOs, which we're really wrapping now into the CCO 2.0 rulemaking that Jeremy described. We're moving forward over the next couple of months. That was a very collaborative process with the CCOs. Originally, I would say maybe not so collaborative up front, but as we were starting to move through the session, we were able to sit down at the table several times. We got great suggestions from the CCOs about how to put this together. And part of the legislation is actually a work group to continue to work with them to refine this over time. Let's see, there are a number of other bills that are listed on the second page of this handout that will affect health system transformation over time. I would like to note SB 770. I think you'll hear a lot about this over the months to come. And really 770 ended up being a combination of two bills. Representative Salinas, the chair of House Healthcare, wanted to look at the potential for Medicaid buy-in and have health policy and analytics run modeling over the next year to really see what this would take to do that. In addition, Senator Manning wanted us to look more closely at universal health care overall. And so those two things came together as one bill. I think there's still some tweaking going on. The Medicaid buy-in analysis component will come first, and then we will move on to the other components that Senator Manning and advocates would like us to look at. And we've all agreed to sit down to the table and do some tweaking to make sure we can get the most out of that over the next couple of years. I think the other bill that was significant for Office of Equity and Inclusion was House Bill 2040. That was an OHA run bill, of course, and we did add some new membership to the Traditional Health Worker Commission. And we're hopeful that that can now be a more robust commission, and hope to see a lot more activity out of it in the next couple of years.
Kirsten, did you have a question?
On the 770, what is the timeline of that work?
So that is one of the things as well, I would say, where it landed versus some of the things that may be tweaked. And Jeremy, I'm looking at you again. I believe for this, it's more precise right now for the Medicaid buy-in component, which I believe we have a report due May 2020 on the Medicaid buy-in component. And then I think we need to go back and talk about what's reasonable for the other pieces.
The bill right now says, I mean, it was very clearly structured so that we would do the Medicaid buy-in, work first, report that back. Then there's a separate task force that's actually supposed to be led out of the legislative, LPRO Legislative Policy and Research Office. That would be a separate task force to basically design a statewide single payer system that would replace all healthcare markets in the state and replace sort of all the entire healthcare system. So that's a lot to bite off. So that's a separate task force, like I said, that would be stood up. Right now, the bill says in September of 2020 would be staffed primarily out of LPRO. We'd be providing a lot of technical support. The bill right now says that their report's supposed to be back due to the legislature in 2021. Seems unlikely that we'll design an entire single payer system in 3 months. So I think that was one thing that the intent was really to start that work and do a sort of progress report in 2021, not necessarily that the work would be done by 2021. So, but that's what the bill says right now, is they'll start in September and be done by January, basically.
There's a lot of there's a lot of work to be done and how to improve upon that component. So we'll be meeting with the advocates and legislators to try to help. Oh, there's a very important bill as well, House Bill 3076. Representative Salinas and SCIU worked very closely to look at charity care policies and have OHA establish a community benefit spending floor. And a lot of that work actually starts more towards the end of this biennia. So we'll continue to follow closely and be working with Representative Salinas and advocates on that. This could be significant in the way hospitals choose to do their charity care policies, and we'll be looking at this. It's also part of CCO 2.0 to some extent.
The work will start actually beginning in January through some rulemaking, and then towards the end of the biennium, the bill calls for basically a sort of tailored community benefit spend for each hospital. So we'll do some rulemaking beginning next year. You know, those actual hospital-specific expectations will start to come towards, I think, the end of the biennium. The other bill that 889, Healthcare Cost Growth Benchmark, we've got a bunch of updates on that. But just so folks know, just yesterday we launched a website under the Oregon Health Policy Board's site for seeking members for that implementation committee. And we put a September 7th date on there for a due date. These are governor appointed. So it's actually the governor's executive appointment form, but just for folks listening, just wanted to let everybody know that we're now actively recruiting for that committee, and go to the Health Policy Board's website and you'll see a link.
Are there any questions about the bills listed here or other bills that you were tracking or thinking about for health system transformation?
And the employer assessment one, you said it's coming back. Do you think that's short session or next long session?
That is a fabulous question, and I don't have an answer to that right now. I think we'll know more probably early fall. We have to know early fall. There were some initial conversations with the governor's office. I went away for 3 weeks. Now Tina Edlin is gone for a couple of weeks, so I think we'll bring that conversation back here about the end of August and see where we're at.
This isn't a question necessarily related to a bill, but it talks about some of the key investments for the OHA budget. And it talks about sort of mental health access in schools. How are schools being defined in this bullet points? Are we talking about just schools in the public school system, or are we also including alternative schools, charter schools?
So that's a great transition to this third area around behavioral health. And the $10 million package that the legislature decided to fund, let me back it up just a little bit to give you an idea of everything in it and then how it applies to schools in the state. So it really was looking at two different ideas that we had that were generated from OHA staff. One part was really focused on suicide prevention, both in the schools and in communities. The other component was we know that we don't have enough mental health professionals in our schools. And I went to a couple of the CCO 2.0 listening sessions, and that was one of the strongest themes I heard as well. So right now, OHA has two ways in which we help support and provide mental health specialists in schools. One way is through the school-based health centers. The other way we do it is a grant program to counties that then those mental health specialists may work at one or more schools in the area, and they're supported by the county mental health. So that is the two ways in which we are now supporting and expanding mental health professionals in the schools. As far as charter schools or private schools, I do not believe that we're currently supporting private school mental health. But the charters may hit the criteria since they could be part of the school system that we're looking at. And the criteria, I'm not sure I have this all, locked in, but it looks at need, assessment of need. It looks at community capacity overall. It looks at the population makeup of the school.
Just to clarify, I meant alternative schools, not private schools.
Oh, sorry about that.
And alternative schools, they tend to have some of the kids that have very high at-risk factors, where kind of placing some of these investments would have a really big impact.
We can go back and look at what schools have received it and if it's open to alternative schools as well. So we'll come back to you with that answer.
The other thing I would just add is the Student Success Act and the $2 billion biennium investment, which is just a complete game changer for education. So we just actually met last week, only 2 weeks ago maybe, with Department of Ed folks, and are starting to stand up a structure internally where we can work much more closely with them. I mean, health and wellness and behavioral health is certainly a big aspect of that. Is critical to overall success for children, and so we really see ourselves as active partners in terms of supporting the education system as they move forward with that act, which includes a number of things like suicide prevention and focus on behavioral health.
Some of the components dealing with behavioral health that came out of student success, which are very complementary. There will be more school counselors. There will be, so we talked about this together, sitting side by side with educators and Department of Education. You have more school counselors. They're able to identify more children that have need. OHA provides more mental health specialists in the school. We're going to be working very closely hand in hand to look at the whole behavioral health system. We'll be able to help translate with our local community partners what the wraparound community approach will be for those kids. So this is going to be a great partnership. We're very excited about it. Are there other questions about that? I would suggest that as we continue that partnership and start looking at how we do that work, that we come back and talk about that as well. I will move on. If you have any questions, you can feel free to give to me after as well. Well, let me say one other thing overall about behavioral health, because we all know this is such a complex area of work and that we have so much to do. So we had some successes this session, but we know we have a tremendous lift in front of us, and we're so grateful to have Director Steve Allen on board. And really the charge now, between now and the next long session, is to understand strategically what it is that we can do that will make a difference, in this system. He is on this right now very closely with the governor's office, taking a look at what would be the most important investments we could make. Okay, moving on So the fourth area to which we were really taking a look at came out of the governor's children's cabinet, which looked across many agencies to say, how do we improve the lives of children and their families, especially those most at risk? One of the items that most directly impacts OHA is the universally offered home visiting program. Lillian is here. She has been very involved in how we're going to roll that out. We have 8 pilots that we're going to be rolling. So 7 to 8 pilot programs will be rolling out across the state. We're working very closely with the CCOs, healthcare partners, community partners, and of course local public health, and trying to make this as successful as possible. That was really the shining star for OHA in that area of work. And then of course we are always looking to how we can support a modernized public health system across the state. And one of the major successes for OHA in this session was an additional $10 million investment to modernize public health in the state, and that is on top of the ongoing $5 million that we got in the long session beforehand. So the road is now clear, and the legislature, there were many legislators that said on record they didn't think it was enough. They wish they could have put more of an investment in public health, and they plan to do so in the following biennium. So we're on that road. Are there any questions about what that might look like? And I especially say that because Lillian is sitting behind me, and I feel very able to ask that question right now. I did meet with Representative Salinas yesterday. It was one of the topics of most interest to her. And I'm saying this to you and as well as to Lily, and I expect that we'll be getting some updates about the decisions that we're looking at with local public health and how to move those dollars forward very soon, probably September.
And just a suggestion. I think there's a lot of us who are surprised that there isn't more activity around the health effects of climate change. I mean, this morning there was I guess there's a report out, a global report identifying areas of the world that will have water issues. And the southwestern U.S. is part of that. I don't know if southeastern Oregon would fall in that. But you know, it seems to me that the public's health is going to soon start to obviously worsen because of what's going on.
OHA, Public Health Division, did a report on the health effects of climate change and resiliency for communities to begin to combat it, or to some degree combat it. And you're so right, and there's so much work to do. And I think we all watched what happened in the Oregon legislature when they tried to propose and pass a bill to address climate change. So I hope that is something the legislature will take up again. OHA is very ready to talk about those health effects, and from the data and research that we have done thus far. It really doesn't even take research to look around the state and see half of the state on fire in the middle of the summers and water drying up in eastern Oregon. It's very clear.
Yeah. Thanks, Holly, for the commercial. We can get both our climate health report as well as the white paper we did that was contributing to the governor's decisions around what went in the cap and trade, and where there were particular areas where policy decisions, climate decisions, energy decisions, what is their impact on the health of people in those communities? We can get that to the board.
I would just say why it wasn't successful in this legislature. The governor's definitely committed to either bringing it back to the legislature or begin doing some actions through executive order. So we will see.
Any other questions, comments? Thank you. Jeff?
Good afternoon. My name is Jeff Scroggin. I'm a health policy analyst in the Health Policy Analytics Division at the Oregon Health Authority. We just wanted to spend a couple minutes sharing the board's priority area timeline draft with you and note a couple things. First thing I wanted to do was talk about the thing Jeremy mentioned, which is that you can go to the board's website, I'll just say it again for anybody who's listening, and apply for the Healthcare Cost Growth Benchmark Implementation Committee right now on the left side of the website. You'll see that committee name there. You can click on it and see the expectations for committee membership and the specific kinds of committee members that the legislation requires, and then the link to the interest form. Please share that with your networks, and anybody who may be listening, please feel free to review it, consider applying. I wanted to also share, you'll see our blue bar up there is the Healthcare Cost Growth Benchmark timeline, and we've got the OHPB review and approval section up there at the top in a red box, and that box is in the middle of the implementation committee benchmark and methodology work. But the intent, and as per the legislation, is the board will also review the final product from the committee. So I just wanted to make that clear. You can see also when the committee is about to launch, set to launch, maybe at the beginning of November, which is also what the website identifies. I'll skip around a little bit here now and go to the pink boxes, the policy priority area known as health equity. Just a couple things to point out here. The OHPB approval process for the definition of health equity is ongoing. The Health Equity Committee has been doing some great work with a lot of stakeholders and really appreciated the board's input regarding the definition of health equity, and we hope to have a proposed definition for your review by the fall. The other thing I wanted to point out here was the middle bar around considering health equity CCO measures and health equity measurement strategy, only calling this one out to say you'll hear more about this later today. Just quickly, as an update regarding the children's health area, that work is on track. The funding opportunity that the board supported, a decision will be made by December 31st by CMS. That's for that 7-year model opportunity. We'll share the decision back with the board when we get it back for them. And then lastly, I just wanted to mention the bottom box, the CCO 2.0 bars. We heard a really substantive update from Jeremy today about CCO 2.0 post-award and ongoing activities. I wanted to also share that we're going to hear from Public Health around the State Health Improvement Plan in just a little bit following the break. So I won't be going into any detail about it, but similar to health equity, we have a presentation following this to get more information about it. The last thing I wanted to share is that following the board's meeting at the Confederated Tribe Umatilla Indian Reservation, we really took to heart the board's request for more reporting back regarding tribal matters, and we're going to use this template as a way to do it. So what we'll do, and we're working with Julie on it, we want to do it intentionally, and she asked that we not add lines to it at this moment, that we do a kind of more considerate process, but we're going to add a couple tribal components into this timeline so we can meet the board's request to have more regular check-ins regarding tribal health policy. That's all the update I have. If you have hard questions, I'll
I don't know if this is a hard one.
defer them to Jeremy.
So are you saying that tribal milestones will be in the existing lines, or are you going to somehow figure out how to add another color on this graph?
That's such a good question, Carla.
Is it a hard one? Should I defer to Jeremy?
You don't need to defer to Jeremy about it. I think we want to work with Julie and the tribes to figure out what the exact components look like and the timelines that are associated with them are to figure out the best way to represent them graphically. They could be little blocks, but it might be an addendum, it might be another sheet, it might be points, it might go in each of these because tribal health is a component of each one.
Question. I'm happy to hear that that's going to happen, so that's exciting. The other thing I would say is I remember seeing this document a couple of meetings ago for the first time, and I remember Brenda and I and maybe somebody else had some very specific feedback on a couple of the priority areas, but I know health equity stood out as one. I can't quite recall some of those specifics. I guess we could look at the minutes from a couple of months ago, but I'm wondering, is this already including that feedback? Does this version include that feedback, or is this the version that we saw 2 months ago?
I'm going to answer a little bit and defer to Jeremy a little bit. The two pieces of feedback that I'm recalling off the top of my head, and happy to review the minutes too, you're right, there may be some more in there, was one, let's really highlight where the board has a decision-making role in this, and so we're trying to do that with these red boxes to be really clear about where the board has potentially a vote opportunity more than just an update or status report opportunity. The other question gets into, and this is why I was looking at Jeremy a little bit potentially, is, I think the board has maybe at every meeting had ongoing conversations about health equity and given specific guidance around health equity. So I know we're going to hear a little bit more about health equity measurements in a little bit, but I think there's also been a robust conversation about improved data completeness and demographic information related to health equity. I think that work is ongoing.
That's what I recall around the decision points, and I think probably worthy of more conversation when we get to the health equity agenda or other parts of if there are other decision points that the board really wants to engage in over the next couple of years. But it looks to me like I think at least some additions were made since the last version.
So then, since this might be a document that is going to continue to show up in our packets, it'd be really nice to sort of really call out any updates that are made based on recommendations from the board member. So it's really easy to understand and easy to identify what's new based on feedback from the previous meeting.
That's a great recommendation. One of the things we can do is maybe we can add it to the legend out here, be a little bit more clear about how we're doing that. So we tried to kind of, you can see in the health equity space, make line outs so you can see the change rather than just a pure edit. But additions, maybe we'll do bold for additions or something like that, so it's really clear.
And so that's clear now. That helps, and that's what I was wondering, the strikeout, if that's some of the edits that were mentioned. And I guess and maybe I know that Leanne's going to present later on, but what I remember from 2 months ago was more that the board members were looking for a much more aggressive action on some of that work, and the strikeouts to me feel like it's not in that direction. It's like going backwards.
Yeah, and I don't want to get in front of Leanne and Stacy. I do think they have some action to report, and I think that will be helpful. And I know that some of these lineouts and strikeouts are just updating our current status following the HPQMC's decision not to move the measure forward.
Yeah, I mean, I think there's a couple things missing from this that we can probably update after the conversation with Leanne and Stacy, but the letter to HPQMC that you just approved, I mean, that's action that the board has taken. You'll hear we've made some changes to the CCO contract based on feedback from the board. So there's a couple things in here that I think we can add where the board's clearly taking action and it should be reflected.
Yep. We'll do a big update of the health priority or the health equity priority area and share those changes at the next meeting.
So I just want to check in with Rosenda to see if she has any comments.
Well, I was just thinking about when Julie was at the last meeting when we met over here at Yellow Hawk. And I think that Julie is really, really well-rounded with all of the 9 tribes in Oregon and also with the urban health programs. And I think that's NARA and and I don't think Chamawa is involved because I think they're federal, the school down there, but I know they have a health clinic. But I think that's a really good idea about including her when you move forward with this table. So I think that's good, and so I really appreciate the attention that's given to the tribes. Thank you.
Thank you. John?
Well, I just thought the visit to the Umatilla Reservation was terrific. I stumbled into, there's an hour-long Oregon Experience show on OPB about the Oregon tribes. It includes that wonderful woman who guided us, and Rosenda, that museum guide was something else. I'm embarrassed that I didn't understand their story. There's an African American story and a Japanese and Chinese story and a Hispanic story. And I think there's some Oregon Experience shows for each of those. And I think we should do everything possible to keep hearing those stories. The story of the Klamath tribe is in what a story, the story of the tribes in southeastern Oregon. These are incredible stories, and we should do what we can to present them. I feel like all the members of some of the committees that are interacting with equity should be required to see that story and then do their work.
Thank you.
Any other comments, questions? All right, so we will be having public testimony after the break. So if you would like to give public testimony, be sure to sign up now. And we will reconvene at 10:30. Thanks. All right, let's reconvene. So we have several folks signed up for public testimony today. Just a reminder, 3 minutes for public testimony. And Jeff is our timekeeper today. And so we will start with Laura.
Do I go to this place?
Yes, go here, introduce yourself, your organization, and then we'll start the timer. TikTok.
Okay, my name is Laura Byerly. I'm a family physician. I'm the medical director of the Virginia Garcia Memorial Health Center. I've been working there since 1994. The clinic's been in business since 1975. Migrant Community Health Center. We work in both Yamhill and Washington counties. We have about 60% Medicaid patients, 20% uninsured patients. Those switch and swash between themselves. We've got 10% commercial, 10% Medicaid care, excuse me. I am here today to comment on CCO 2.0 and Trillium entering the market here. Primarily, that's what I'm going to grouse about. I want to talk about choice, continuity, coordination, and complexity, and I'm just going to throw a line in about climate at the end. The choice, I heard just this morning that the people who receive this benefit don't care that much about this choice, and I have personally witnessed people being completely confused about these choices that are being offered to them that come. And I'm concerned that the way we are going about continuity of looking at I think I understand it's looking for a claim 1 year back will then put people forced to make a choice because there hasn't been a claim in 1 year, where for many people it is not needed to come in within 1 year. So that lack of a claim with a primary care provider is going to force a choice that is meaningless, except for that they won't get to come back to us. So there's continuity. There's also continuity of data. So we had a very bad experience with the continuity of care with family care with that transition. It was very hard to get the information to move across CCOs. That seems like it could be improved, but it didn't yet. I mean, I don't have experience of it working well. All right, then we get to coordination. The more groups we have to interact with, the more difficult it becomes to coordinate. There's only so much bandwidth for the staff, and they have to learn. Right now, in our situation, we have complexity already with HealthShare. That's a reality that's not going away. Introducing yet another group with whom we need to interact, develop relationships, understand how their programs around quality improvement are going to work. There's just a lot of complexity added for no particular strong reason. The members, the Medicaid members who are receiving the benefit, they aren't caring about this. Somebody else is caring about the ability to have another CCO in this region. I don't think they care. Not in my experience of members. So then the other part about coordination is we have to coordinate with there are care coordinators at the CCOs, so we have to deal with, because we have RAIs, we have to deal with different care coordinators already, and we have another CCO, and why CCO, and I have to say that a bad application doesn't mean a bad CCO. Let's see, we have to write contracts with all these different people, so our administrative staff is now having to write more contracts, and we have to remember that we also have all the other private insurance groups that we're having to deal with, so adding complexity is not adding quality at all. And we're adding a player who, the only way, given the benefit is fixed and the amount of money is fixed, the way they're going to make profit is by what? Either having poorer administrative services or cheaper services in some way for the members. So yet another reason I'm not sure that we are adding to the health of our Medicaid population in this market.
We're just past 3 minutes.
And climate is the highest, most serious thing that's going to impact human health across the entire world, and we got to take that seriously. Thank you very much.
Thank you, Laura.
Nice one.
Thank you.
I knew you could do it.
Tried to cram a lot in here.
Mike?
My name is Mike Huntington. I'm a retired radiation oncologist from Corvallis. Been active with Physicians for a National Health Program and Mid-Valley Healthcare Advocates. On one of my topics, I speak for Mid-Valley, and the other one for myself. The first topic is that I feel one program should be dropped from the Oregon Health Plan and from practice in general, and that's value-based payment. So I speak for myself on that, and I'll explain just a bit. The other one that has just been added to our system, and it's been talked about already, is 770 Task Force, which I hope we get fully behind and help it to move quicker than the schedule says, or as quick as the schedule says. So regarding value-based payment, despite this being accepted and woven into the fabric of our healthcare vernacular, it's much like the fable of the emperor with no clothes. It is an unproven idea that is turning out to be administratively complex, burdensome, and expensive to implement. It's driving doctors out of independent practice and does not appear capable of helping us achieve the quadruple aim goals of improved care, improved population health, decreased costs, and improved physician morale. Please read the article that you have, and for those in the audience, there will be copies that you can pick up on the way out. This article is by Stephen Kimball, MD, former president of the Hawaiian Medical Association. He's a retired psychiatrist. So this comes as a voice crying from the Northwest wilderness, I hope, and from Hawaii that may be heard by the emperor. Value-based payment is not good. Following metrics is good. And I think the way those metrics should be used is to be placed in a graph form without identity to who is falling out of the norm, but everybody will know. When you do this in a hospital, you report how people are performing. If they're doing too many tests, you don't have to say their name. You put it on a chart, and you see the chart of how they're doing. In contrast, we will definitely urge your support for the task force that has been created by Senate Bill 770. And so I have copies of that for everybody here at the table and for those in the audience. Also, for the Oregon Health Plan, we have people who want more portability, especially marginal income people who have to migrate for work and battered spouses who have to leave the community to get the care they need. Thank you, by the way, each of you, for serving on this board.
Yes. Well done.
Thank you, Mike. Come back and talk anytime. Art?
Is this on? Mm-hmm. Oh, perfect. Thank you. Good to be back. Art Suhrzewski. I represent Family Care Health. Yeah, yes, we're still around, although we don't have any more members. We were a CCO in the Portland Tri-County area until January 31st, 2018, and we have experience serving the Medicaid population in Oregon since 1985. As you know, the Oregon Health Authority recently announced that CCOs collectively earned $188 million in quality bonus funds for 2018. Our analysis of CCO financials shows that these quality funds help boost CCO profits or shrink losses derived from capitation rates. And for example, in 2017, the statewide profit margin tied to premium dollars or capitation rates was negative 3.9%. or a statewide loss of nearly $160 million. 13 CCOs in total had steep losses. 3 CCOs that were profitable collectively made $6.8 million that year. After adding quality funds, the profits increased to $22 million. Everybody else either lost money or made a little bit after adding back the quality funds. Current CMS regulations require that premium dollars and quality bonus funds are separate for the purposes of evaluating profits and medical loss ratios. And as you know, historically, nearly every CCO has made 100% of their quality funds over the course of the 5 to 6 year CCO contract. The board should ask what exactly the state and its constituents get for all of this money. Is the quality program focused only on small, short-term quality gains and CCO profits and not real healthcare transformation? Next, I want to talk a little bit about the CCO 2.0 process. In 2012, this body adopted a plan calling on CCOs to be, quote, responsible for the integration and coordination of physical, mental, behavioral, and dental health care for people eligible for Medicaid. That sounds a lot like CCO 2.0. In 5 years, will we be back forming new collaboratives and work groups in response to CCO's failure to integrate and invest in behavioral health? I think we need to hold the CCOs and the OHA accountable in moving that ball forward. Here are a few examples of the deficiencies identified by OHA in its evaluation reports. Quote, applicant failed to explain how they will manage behavioral health. Quote, this applicant has some critical deficiencies and does not seem to understand the key principles of CCO 2.0. Missing detail in one application is, quote, suggestive of missing underlying processes, knowledge, or other infrastructure. Quote, applicant demonstrates a lack of engagement in moving toward treatment of behavioral health conditions. Quote, applicant appears to misunderstand what cultural and linguistic competence is and uses the wrong acronym for LGBTQ. These are 5 applicants that received CCO contracts. In regards to financial solvency, OHA voiced concerns about primary health CCO's financial conditions stemming from losses incurred in 2017. 13 CCOs lost money that year. Despite its improving financial position and being the top performing CCO in the state in a number of quality metrics, their application was rejected. And I simply ask, why?
Art, you're over.
Thank you. I just want to add family care transition members in 2018, and we had high-risk members identified early on in that process, and we had member files maintained on those members, and we shared those early on with the Oregon Health Authority. Thank you.
Thank you, Art. Sam?
You may not be able to read my horrible handwriting, so it's Sam Chase. I'm Sam Chase. I'm the exec. You got your Thank you. Is this one working?
Just with the button up.
Got it. Okay. Sam Chase, the executive director for the Coalition of Community Health Clinics, and am here to talk about the Trillium application and the CCO 2.0 process. I just want to explain a little bit about the Coalition of Community Health Clinics. We are 17 member clinics in the Portland area, serving nearly 80,000 people annually, who are 9% of those folks are OHP or uninsured and are often overrepresented communities of color within our clinics, and homeless and other folks who are struggling in our community. Together with our partners, Virginia Garcia, Multnomah County, and others, we represent more than 200,000 of those lives. There is a very strong consensus that Trillium is really not ready at this point to participate in our coordinated care system. It is really based on the assumption that competition is good, and that may be a factor in other communities. I can't speak to that, but in this community, we went through the process with family care. We learned a lot during that process, and the the benefits in this complex system of having competition for competition's sake really does not compare to all of the factors that are very problematic with having a second CCO, and in particular Trillium, who's really open to learning, but really has a lot of learning to do, frankly. There is not an understanding of this community. There is not an interest in engaging at this point in community discussion. We've worked very hard to try to have conversations, and we have not been able to do so at this point. But we are concerned about the continuity of care and disruption for patients, and I urge you to continue to, as you go through this process, really focus on what is going to make a difference for the patients. Because I think that's been out of the equation. I think that's why so many folks in this community are so well aligned to say this is not the time for Trillium to come forward. And it's not just the folks who are engaged in HealthShare, it's the folks who would benefit from both CCOs and contracts with both CCOs. But our safety net clinics deal with a lot of difficulty in the reassignment process. When they have contracts with different CCOs, it's a huge time consumer in their administration, so they spend a lot of time and resources that get sucked up into that process. No matter how well we design the assignment process, it still is very confusing if you're working 2 jobs and you're trying to keep up. You know, if you're like me, sometimes you don't even open all those letters that look like junk mail that come in, right? So it's a very difficult process. From that, it splits our community capacity. We've worked with HealthShare. We have a lot of things we need to work on with HealthShare, and we want to really double down and put more effort into making that model successful. This would split us into really having to go back to ground zero with another CCO, and would suck a lot of community engagement, time and energy out of the process and our ability to do that. So I'm over time, but really appreciate you hearing us out. Thank you.
Thank you. So I just want to thank everybody who came to provide us with comments today. It's always very useful, so thank you for taking the time to do that. We are going to be talking about the SHIP now. So we have Kara, Christy, and Lillian.
Hello. Members of the board, Chair McKelvey, I'm Lillian Shirley, the Public Health Director, and we're very excited to have this opportunity to share with you the process that we've been involved in. I want to harken back to Holly Heiberg's presentation when she talked about the Oregon Health Authority's legislative agenda and how we're trying to build continually in our transformation effort and moving along the road to more upstream, stabilizing care across the state and the integration of care. And this is something that is a requirement of state public health departments, and this will be our 3rd state health improvement plan. And we really have learned in the past, I think from our understanding of community engagement, as well as what is the difference between real social determinant of health work and then, you know, as a contrast, helping me, who has, I would say, I have had a social determinant of health environment. So you're helping me by giving me housing, you're helping me by giving me other support services, but you're helping me with the consequences for me and my family of inequity and social determinants of health. And we're trying to make sure that in the continuum of care for the Oregon Health Authority and what our responsibilities are, that we in public health can continue to stretch that to continue to move upstream to really bring forth how we can work across the state agencies and community groups to address social determinants of health in the long haul, not in the immediate haul. So I'm going to introduce both Kara Biddlecombe, who is the Director of Policy and Planning, and then she'll introduce Christy, who has done the yeoman's work when you see how much engagement there has been here. So I want to make sure that people get to meet her and be able to ask direct questions.
Great, thank you. So we'll get started with some brief objectives for this morning. So
We'll have an opportunity to talk through the process for developing the 2020 to 2024 State Health Improvement Plan. I think this is a really ripe opportunity to talk about ways that the work that we're doing on the State Health Improvement Plan supports bidirectionally the work that's happening with CCOs and other partners through community health improvement plans. And then we can have an opportunity for some dialogue around ways to improve collaboration on SHIP priorities across the Health Policy Board committees. So before we go further, I actually also want to do another thank you to Dr. Bangsberg. So he, of course, is the representative from the Health Policy Board on the Public Health Advisory Board, which is sort of our oversight for this work. And he also serves on the partnership, which Christy will talk about a little bit more in her section, but is also very highly involved in us developing our priorities for 2020. So before we get there, what is a state health improvement plan? So this is really a tool that states have. Most states do have state health improvement plans that helps us to identify our health priorities, that helps us to address unjust and unacceptable disparities that are within our state. It can be used as a tool for collective impact, where we can work across sectors with our partners on the leading causes of death and disability and health disparities. It's a tool for aligning our efforts. We have used this as a strategic document within the Oregon Health Authority, and I'll give you some examples of how we've done that. And for us, from the public health perspective, it's one of our prerequisites for national public health accreditation. Similarly, for local public health authorities and tribal public health authorities that are seeking to be accredited, community health improvement plans are also a prerequisite that they have. So who implements the State Health Improvement Plan? Of course, the Oregon Health Authority, being that we're the ones helping to forward this effort. We have a key role, but it goes far beyond what the Oregon Health Authority and the Public Health Division do. The State Health Improvement Plan pulls in the healthcare system, elected officials, state and local health departments, education system, employers, criminal justice and law enforcement, many other sectors, transportation, housing and human services, community-based organizations, faith-based organizations, and philanthropic partners. The Public Health Advisory Board, as I mentioned, Dr. Bangsberg sits on that as well as a partnership, but the Public Health Advisory Board really provides our oversight. This is both for the state health assessment, which is our larger look at data around health in the state of Oregon, but also provides oversight for the implementation of the State Health Improvement Plan. Over the course of our current State Health Improvement Plan, we've been providing regular updates to the Public Health Advisory Board on our progress, as well as reporting that progress annually to the public. So we have we update our data on our measures every year and put that forward, and we are able to engage in some really robust discussions with the FAB on things that we could maybe consider doing differently or better to help move our progress forward. We had representation from the Public Health Advisory Board on the development of our state health assessments. We had a steering committee for that. Would you like to say?
Go ahead.
And then, of course, as I mentioned, Dr. Bangsberg is on the partnership, and we have other FAB members that are also involved in the partnership and on our subcommittees that are going to be moving forward. Okay. So before we jump into the 2020 State Health Improvement Plan, we are still in 2019, so I want to talk a little bit about how we've used our State Health Improvement Plan to move forward state public health priorities. So our current State Health Improvement Plan, and you'll notice when we look at 2020, the list of priorities looks pretty different. But these are the 7 areas that we've been addressing. I think many of these have come to you in other forums over the years. But our priorities have been to prevent and reduce tobacco use, slow the increase of obesity, improve oral health, reduce harms associated with alcohol and substance use, prevent deaths from suicide, improve immunization rates, and protect the population from communicable diseases. And so these have really taken a health focus, and we've been able to use the State Health Improvement Plan, particularly in how we frame out health priorities in the state of Oregon and help to use these as our platform. So one key area that we've really used the current state health improvement plan to move forward has been on the CCO incentive measures. So it kind of seems like each year we've inched forward and brought more of the CCO incentive measures and SHIP measures in alignment. So this will give you a sense for where we're at with 2020 CCO incentive measures. But you'll see that immunizations, depression screening and follow-up, cigarette smoking prevalence, SBIRT, dental visits for children, hemoglobin A1C poor control, and then initiation and engagement in treatment for drug and alcohol use all align with those 7 priorities that we're currently advancing in our SHIP. So this has been a really important tool for us within the Oregon Health Authority. Another area where we've had significant alignment with our current SHIP has been with the CCO quality improvement initiatives. So 2 major pathways for that have taken place over the last several years have been through the direct technical assistance to CCOs that the Transformation Center has been providing, specifically trying to look across the public health and healthcare system to reduce tobacco use prevalence and increase access to childhood immunizations. So that's been an area where we've really collaborated across with local public health authorities and the state public health division with CCOs to make some changes in these areas. And then the CCO performance improvement projects have intentionally aligned with SHIP priorities as well. So lots of work on opioids over the years as an example. So I'm going to pass it on to Christy Hudson. She's our policy analyst working on forwarding the current development of the 2020 State Health Improvement Plan.
Good morning, everybody. Thank you for the time. So looking towards the next State Health Improvement Plan, it really provided an opportunity to consider the process that we have used in the past, and a decision was made that this time around we would use an evidence-based planning tool. We went with the MAP framework, Mobilizing Act for Action through Policy and Planning. It's frequently used by CCOs and local public health departments in their health assessment and planning work. So it was a good fit. And I'm sure some of you are familiar with the MAP, but just to give you some understanding of why we went with the MAP framework, and it was really about the MAP, how the MAP helps create a paradigm shift in health planning. So instead of operational planning, where we often work in silos and are often asking, are we doing things right? We're trying to move to more strategic planning, where we're working with cross-cutting teams and other partners and asking instead, are we doing the right things? Instead of a plan that really focuses on the public health system, we're trying to create a plan that is useful to all communities and communities that are concerned and trying to improve health in their community. Instead of a needs assessment or deficit assessment approach, we're looking more towards the strengths and assets that exist in our state. Moving from a medically oriented model to one that is more upstream and takes a broader definition of health and well-being for people in Oregon. Instead of a plan that indicates the Oregon Health Authority as being primarily responsible for health, we're trying to create a plan that uses more of a collective impact approach. Really, everyone can see themselves in this plan in improving health across the state. And I think most importantly, instead of a plan that is focused on equality, we're trying to move to one that is equity focused primarily for priority populations.
So perhaps you're going to touch on this on a future slide, and if you are, I'm fine, I'm waiting. How do you determine success?
Great question. Yes, we will.
Okay.
We'll get that.
And we hope you help us.
So the MAP framework outlines health assessment and planning over 6 phases. So the state health assessment, or SHAW, was developed over the first 3 phases of MAP. The SHIP will be developed and implemented over the second 3 phases of the MAP. We are actually now entering into phase 5, where we are formulating the goals and the strategies for our next state health improvement plan. But to back up a little bit, this work really started back in 2017 when we convened the steering committee for our state health assessment. And the task of that steering committee, the first task was really to identify the overall vision and values that will guide this work through implementation of this SHIP. And so this is the vision that was first created by that steering committee and later amended by the partnership, and it reads, Oregon will be a place where health and well-being are achievable across the lifespan for people of all races, ethnicities, disabilities, genders, sexual orientations, socioeconomic status, nationalities, and geographic locations. So a very clear commitment to achieving equity through this next plan. You also see that demonstrated in the values that have been identified by the partnership and will be utilized by the subcommittees that will be standing up here very soon. The state health assessment was published last summer and includes a very comprehensive summary of both quantitative and qualitative data that we have about health. So it describes health within 5 categories: the social determinants, environmental health, prevention, health promotion, access to clinical preventative services, and communicable disease. While the state health assessment is done every 5 years, there's a set of complementary state health indicators that we update annually. There's about 70 of them. And those are analyzed by county as well as race and ethnicity when we have the data available. So we hope that this has been an important resource for CCOs, local public health, and other partners in their own work. Big part of the SHIP has been around partnership, and we really think about those partners within 3 circles of influence. So the first circle, there is a core group of staff, primarily here within the public health division, but we've included some additional folks in this past year from other divisions as well. And this group is really the support team. We provide the staffing support for all of these groups, as well as ensure that we're maintaining alignment with the MAP framework. The partnership, that's our community-based steering committee. They are really the decision makers in all of this. So they set the vision, they set the values, they determined the priorities, they will approve the plan and ensure that we're maintaining to the vision as we implement. The partnership now also will include many other partners in a subcommittee process that I'll talk about in a few minutes. And then finally, we have a very large community engagement effort. This has been critical throughout the state health assessment and planning process, and will continue to be necessary as we begin implementation. I'll tell you a little bit more about how we've approached that. The FAB, the Public Health Advisory Board, is also noted here. As Kara mentions, they provide overall accountability for the SHIP and monitor our process.
So one of the questions I've always had is, how do the CHIPs feed into the SHIP, or how does the SHIP impact the CHIPs? Because I don't see CHIPs on here. Is that on here somewhere?
It is, yeah. We'll get to that in a bit,
Thank you.
because there's been some great, some great and important changes within the CCO 2.0 contracting process that will help support the work that's happened here in the SHIP. In terms of the development and the process, we certainly did look at the community health assessments when we were putting the SHA together, and similarly, we looked at some of the priorities within the CHIPs when informing the SHIP. That information was shared with the partnership. People are pretty much saying the same thing, and you see that pretty clearly. So, which is great, yeah. A little bit more about the partnership. So this group is 21 people strong at the moment, and includes representation from public health and healthcare. Regional health equity coalitions are included. We've got partners from a number of different community-based social service providers. Yeah, so they're a great and a very engaged group. We're very, very thankful for the work that they're putting into this. So the partnership last fall, they were asked to identify a series of strategic issues that they wanted to put forward to the community. And these issues primarily came out of the state health the state health assessment, but they also looked at the CHAWS and the CHIPs during this process as well. And they identified 3 criteria that they used to pull out these strategic issues. The first one was they wanted to look at issues where we know we have significant disparities. The second was they wanted to look at issues that were of significance, meaning they impact a lot of people and or are often associated with death or disability. And finally, they wanted to look at issues that are upstream determinants of downstream health outcomes. And these are the 14 issues that they came out with. These were later shared with the Public Health Advisory Board for comments and feedback as well. These issues are all obviously very important, but it wouldn't be feasible to address all 14 of them in a state health improvement plan. So the next thing we did was we put these issues out to community, and we basically said, you know, of these 14 things, which 5 are most important to your community? And we did that through a number of different mechanisms. The first one was we had an online survey that we fielded through partners around the state. It was available in both English and Spanish. We also took a bit of funding from our CDC block grant and put that out to community-based organizations. So we were able to fund 7 of them. You see them listed here: Eastern Oregon Center for Independent Living, that's based out of Pendleton, serving people with disabilities. Self-Enhancement Incorporated is a nonprofit based here in the Portland area, primarily working with African American community in the metro area. Next Door is a regional health equity coalition located in the Gorge out of Hood River. Unite Oregon, this is a statewide coalition, but this funding specifically went to their Southern Oregon chapter. The Q Center is a nonprofit here in Portland serving the LGBTQ+ community. Micronesian Islander community is a part of APANO. They work primarily with folks from Micronesia and other islands in the I-5 Valley. And finally, Northwest Portland Area and Health Board. So they worked with all tribes, all federally recognized tribes in Oregon. So they received a little bit of money, and I'll share a little bit about kind of what we learned from them separately from the survey. And then we also had a kind of open invitation to other agencies, coalitions, communities, really anyone who wanted to chime in on these strategic issues. We were happy to hear from them, and so we had many people submit comments or letters through social media, emails, etc. So a little bit about who we heard from and what we heard. So in total, we heard from over 2,500 people, either through the surveys or the efforts of the mini grantees. And we are pretty proud of the demographics of those folks as well. So those folks were representative of affected communities, primarily race and ethnicity. We did a good job hearing from people outside of the I-5 corridor, so heard a lot from folks in our rural and frontier counties. We did hear from more women than men, and we definitely also heard from people who are more educated. And we also have some learning to do in terms of getting youth voice into our process, as we didn't hear from many people under 18 years of age. In terms of what we heard, pretty consistent themes, and people are being very clear about what they need to improve health, and that is the social determinants of health. Probably no surprise to you, but aligned very closely with what you all heard during the CCO 2.0 engagement work as well. So the call is very clear. We also heard recognition that the issues that we had presented are very interrelated. You can't really do one without thinking about the other, so that's important to consider as we move forward as well. And this last point, I think we really take to heart. People were very grateful that we were asking for their opinion, and also very wary that it was actually going to result in any real change. And so that's something that we are taking very seriously as we move forward. A little bit more about kind of what we heard from those 7 community-based organizations. You'll see the number of people that they were able to engage through their efforts, and we really left the method up to them. So many of them used the surveys, many of them held kind of community events, some went door to door, some put this information out through community health workers, some people showed up at laundromats or restaurants in their communities, so it was really great to see the diversity in methods. So I think that was a real success for this process. And in terms of what we heard, you can see the priorities that came out from each of those communities. For the most part, these were pretty similar when compared to the overall survey results. But 2 issues that definitely came out higher here were institutional bias and food insecurity. So I think those were the 2 that were somewhat unique to the voices here. And all of this information then was presented back to the partnership in February, and based on that feedback, here are the 5 priorities that they landed on for our next state health improvement plan. So we'll be looking at institutional bias, adversity, trauma, and toxic stress, the economic drivers of health. So this will really be looking at everything from housing to transportation, wage and employment related concerns, access to equitable preventive health care, and behavioral health. The partnership also helped to develop this health equity framework that will help to inform the goals and strategies that are identified for each of these 5 priority areas. So across the priority areas, we'll be asking subcommittees to develop policy-related interventions, strategies that address the daily living conditions. So this is where we imagine, in particular, the work of our cross-sector partners coming out. So, what is Oregon Housing doing about this? What is DHS, ODOT, Department of Education, et cetera? And then finally, we'll also be asking for individual health-related interventions. So things like education, clinical services, and other direct services will also be called out. Across those 5 priorities, we'll also be really focusing on priority populations, and specifically we're concerned about people of color, people with low income, people with disabilities, people who identify as LGBTQ+. We'll also be looking at geographic disparities. And then finally, we'll also be wanting strategies across the lifespan with particular emphasis on the needs of children and older adults. And this really comes out directly from what we heard from community during our process. So to get a little bit more specific about the subcommittee work, as we mentioned, we've got subcommittees that are going to be starting just in a couple of weeks here. So we've got one for each priority area. We are very excited that we have recruited an additional 97 people from 62 distinct organizations to help us in this planning process. So it'll be great, I think, to hear from such a diverse number of people, and these include folks from other state agencies, community-based organizations, as well as people with lived experience. So we're very excited to see what happens when you get all these people in the same room, to see what comes out of it. Subcommittees will be asked to identify the overall goal for each of these priorities. They'll also be asked to identify objectives and strategies. They'll also then be asked to identify the measures, so both outcome measures as well as process measures for each of the strategies that come out. And there'll be some sort of ongoing data system where we track and monitor and report out on those measures annually as well. Subcommittees are also responsible for helping us with communication back to their agencies, to their communities, both to provide information and about what's happening in those subcommittees, and to bring feedback back to the subcommittee on how people are feeling about the conversations that are happening there. And finally, before I turn it back over to Kara for a little bit more about some CCO 2.0 opportunities, particularly as they relate to the CHIPS, just one word about collective impact, which is another approach that we are looking to, particularly as we start to move into implementation of this plan. And collective impact really relies on these 5 principles. So the first is that you have common agenda. So we've already set this, I think, with the vision and the values that came out of the partnership. We also have set this with the priorities that were really driven by both data and community voice. The second condition is that we'll be setting up a shared measurement system. Again, the subcommittees will be identifying measures for each of those strategies, and those measures reported on annually across sectors. So that also will help to improve accountability across the state system. The third condition is really about mutually reinforcing activities. This will be a big part of the work of the subcommittees. So again, aligning what already exists, and then improving the coordination for existing and new strategies that come out of the plan. The fourth condition is related to that communication. Again, in ensuring that subcommittees are communicating back to their communities and really focusing on building trust, that we are all working on this together. And finally, the backbone support. This has really been the Public Health Division. With inclusion of others now, it's really becoming what we see as the Oregon Health Authority providing the support for this effort. And with that, I will turn it back over to Kara.
And then I promise I'm just going to do 2 quick context slides and then have time for questions and more discussion. I do hope that the next 2 help to answer one of your questions, Dr. McKelvey. In the development of the CCO 2.0 contract, we've been trying to be really intentional about how we better align and leverage community health improvement plans and the state health improvement plan, because there are a lot of efforts going on in communities, and one could even say in a given community there may be multiple community health improvement plans as of right now, between requirements that CCOs have, requirements that local public health authorities have if they're seeking accreditation, and then of course hospitals as well, as a part of their IRS status for nonprofit hospitals. So what we've tried to do is lay out some firmer platform, some more fertile ground for us to be working together. So the first opportunity in the CCO 2.0 contract is around alignment between community health improvement plans and the state health improvement plan. So in the contracts, community CCOs are required to include at least 2 state health improvement plan priorities in their community health improvement plans. Those are 2 in order to be flexible based on local need, and the statewide strategies that are being implemented, because we understand local context is really important. And then also making sure that we're really intentional around the community health improvement planning process being equally as engaged in community as we are trying to set forward as well. And I would actually say that in many communities we're learning from what's been going on and having that inform the state health improvement plan process. The other area is around the health and equity spending programs plan that CCOs are required to submit, and so those plans need to align with community health improvement plans. So if you sort of draw that logic, we're trying to bring the same partners together to the table of the same responsibilities around assessments and planning, and then drive those investments together towards shared outcomes, which I think in many places has already happened organically, and for those that it hasn't, it's trying to be more intentional about how we do that. So I'll pause here and see what questions we might have, and then we have some discussion questions for you as well.
Questions? You have done a marvelous job.
I've got one.
Oh,
Just, you know, you all mentioned measurement. You know, welcome to this discussion.
Yeah.
You know, there's a lot of pushback going on about measurement, and I think a lot of your measurements actually don't come from the health system. They come from the people, from the population, and I think it'd be good to have more of that, and you know, be prepared, you know, to be involved in the discussion. You know, like at measurement and scoring, there was actually a bit of a discussion about whether they should shelve vaccination rates. Because it seems to have topped off, and really the problem is specific communities that are resisting vaccination, and what can we really do about that? Well, what can we do about that? You know, and so I think I hear this, and you all might have a more creative approach or solution to that than the delivery system.
Anyone else? All right, you want to show us your questions?
Oh, sure. And I'll try to go back to your first question, too, which was around how we measure success. And I think it's important to be really humble in this process, that we've never done this work this way before. So I anticipate that as we go forward, we're going to be learning a lot. And I hope that the fact that we've set things up the way that we have with a partnership and our subcommittees and having broad involvement will allow us to receive kind of on-time feedback about the things that we're doing well and things that we need to change so we can make course corrections. So to me, success would be one, that we maintain and grow the engagement that we've had in this process, so that we can sort of get beyond that concern that Christy highlighted, that, you know, there's maybe this question about whether we'll be able to deliver on this work, so that we can build that trust back. And then second, I would say we're in the process of developing those you know, measures that we want to see, identifying what data we need to collect. And to your point, Dr. Santa, I think it's It's going to, a lot of it actually even fall outside of OHA in terms of who has the data that we need to measure progress in these priorities. So collecting all of that and then seeing how we're doing over time, and I think we're not going to be able to do that work alone. So that's where the partnership comes into play. I hope I answered that question. All right, so we just have some broad discussion questions for you. What are some key opportunities to further our collaborative work on institutional bias, adversity, trauma, and toxic stress, economic drivers of health, access to equitable preventive healthcare, and behavioral health? We're still in the forming stage, so we are definitely open to feedback.
So I just want to let you know we have about 10 minutes. I think this question could take an hour.
Take a lifetime.
Yeah. May I suggest, while this is a very important question, could we move to your next question? Because I think this one might be, I hope, a little bit more straightforward,
yeah.
And we could possibly answer in the next 10 minutes.
Sure.
Okay, all right, thank you.
Okay, so where do you see alignment between Oregon Health Policy Book priorities and the 2020 to 2024 SHIC? That's the first part of this.
So I think that I was pulling out Jeff's timeline here, or is this actually Trophy's timeline?
We share it.
Yeah. And there's some obvious, I think, crossovers here with the children's health and the health equity. I think those are natural fits there, so I think there's good alignment there. Oscar, did you have a comment?
Yes, and it was kind of related back to the earlier question. And I know we're trying to get to these ones, but I want to make sure, just like a quick note, one of the ideas that I would put out there is that I think one of the challenges is when we're actually trying to have the voices that could help us really tackle this challenge, those are the voices that have the least amount of capacity to be authentically engaged in the process, throughout the process. So I was really happy to hear that you were able to find some grants, some grant funding to involve specific and intentional communities to create, surveys and get community input and focus groups. But I would really sort of recommend and challenge you to move beyond, in addition to that, to move beyond that and also provide investments in having those folks be at the implementation level and be part of the policy decision-making level. So not just to be, doing community engagement, but to pay for their time and their capacity to be sitting at the table throughout the process.
Can I just go one step further? You're talking about Oscar. Thank you for that. Which is also get them involved in the evaluation process, so that it's not just statistics, but it's like, how does it feel? This is where we were aiming. How does it feel? And how can you help us have more impact, if you will, or what more directionally correct kind of areas for trying to walk down that path? Yeah.
I think the other question you had is ways would you like to see the Oregon Health Policy Board and its committees further collaborate on the SHIP? And I think there's crossovers that could occur, certainly with quality metrics. I'm thinking a lot about quality metrics here, as well as health equity. So I'm assuming you have those relationships in place, but if not, I think those are good relationships to develop a collaboration. I think one of the big questions that I just want to go back to is the connection between the SHIP and the community health improvement plans. I think they're done differently in different counties. In Coos County, that was headed up by public health, and it's volunteers. And so as a result, I think it's very difficult sometimes to be effective with these plans, and they're so important, and what you've outlined here is so important. And so I really hope there's some thought and work on how this moves up and down between the counties and the state, because you made the comment they're interrelated, and they're interrelated on so many levels, and I think it's really important to support that, not just at the state level, but at the county level too, so that there can be that impact. John?
Yeah, I think this is the first time I've seen the CACs mentioned in a process as being part of it and accountable. I know we talked a lot about that in 2.0, and now maybe we're going to start to see this. And I think it would be very interesting to hear back your sense of how are those CACs doing. You know, are their CCOs being supportive, or, you know, is this a kind of more of a symbolic thing than a real? This seems kind of real to me, and so that's interesting. It also, you know, David's suggestion about a retreat with the CCOs. Maybe we should have some of the CAC folks come too.
So this is just to assure you, John, for those of us who, I mean, I am enormously attached to the community advisory committees. I have been from the beginning, as Jeremy knows, and I do think that we at OHA, and this may be a pathway, you know, to really give them some oomph, let them know we got their back, and someone is listening, and beyond just the contracting thing, like what are we hearing and what do we need to bring to the discussion of are we achieving health in communities?
Rosinda, I just want to touch base with you and see if you had any thoughts or comments. Okay.
Eric, could I just punctuate? I just want to compliment Christy, Kara, and Lillian and the entire team on this process, sort of being part of it and watching along the way. Just took really complex issues with really deep, authentic community engagement, very intentional. And they took those complex issues and distilled them in, I think, a really productive, useful way, you know, moving towards measurement and accountability. I think keeping that engagement will be really important, as has been mentioned. But also, I think it reinforces an important thing for the Oregon Health Policy Board, that we are not just a CCO policy board, but really invested in health of all Oregonians, which means moving out of the healthcare system to the population level, moving upstream. And I see that this is very much should be integrated in parallel with the CCO. And so congratulations, very well done. I'm really glad to be part of it.
Thank you so much, I appreciate it.
Carla, this is Rosinda.
Yes, Rosinda.
Yeah, I had this on mute, and I know we're moving some books around, but I just wanted to make a comment on I don't know which side it is, but it has to do with what are some key opportunities to further collaborative work on institutional bias and trauma and toxic stress. The trauma part, I know, I'm not sure how long that's been talked about or has been discussed as a part of, you know, reasons why people may have some of the needs that they do have, but I really think that oftentimes with Native American Indians, we tend to, you know, not want to put ourselves like we are victims of some kind, and that we really kind of try to belittle or something, you know, with the trauma. But nowadays it's coming out more, which is good, and people can feel like, well, I'm just not looking for something to make excuses for myself, because the trauma is real in some people, and I'm sure not just in American Indians, but in other areas too. So I just wanted to say sometimes it's a very sensitive area that and needs, you know, someone, you know, when you're discussing it, that you really don't sometimes want to just come out and start talking about, well, this happened in the boarding school, this happened to my grandma, and those kinds of things. So since it is sensitive in some areas, especially for middle-aged and elderly people, but I think that it's becoming more talkable with a lot of people. So I just wanted to comment on that. Thank you.
Thank you, Rosinda. And thank you again. So we're going to have Leanne and Stacy join us, but in the meantime, Jeff has let me know that we actually have to do a voice vote on the minutes. So with the one change, which is the welcome and call to order was actually done by David and not by me. All in favor of approving the minutes, say aye.
Aye.
Opposed? Okay, thank you. Welcome.
Thank you so much. For the record, my name is Leanne Johnson. I'm the Director of the Equity and Inclusion Division for the Oregon Health Authority. And with me is...
Is this on? Is this on?
We can pass it back and forth. We work very well together. Good morning. My name is Stacy Schubert, and I continue to be the Interim Director of Health Analytics within the Health Policy and Analytics Division.
Thank you. And before we get into our presentation regarding health equity and health equity metric work, we have some business before that regarding approval of, or hopeful approval of 4 new members for our Health Equity Committee. In your packet, you received information about 4 members that have been vetted. They have been not only vetted in terms of their individual qualifications, but also the outreach that we did around getting these 4 people to this point really included a gap analysis of what was necessary in terms of representation from a variety of demographic perspectives, including geography. So we worked diligently to do a gap analysis, to do outreach that reflected that analysis, and then these are the 4 names that have come forward that we're hoping that you will approve. Ashley Harding, Kate Wells, Deb Morrow, and Rakesh Gott. I don't know if it's Gotti or I'm not quite sure how to pronounce Rakesh's last name, so pardon me. So these 4 individuals will round out the Health Equity Committee to our 15, number of 15. And so more than happy to take any questions or provide any information that you would be interested in having. I will add that when you go to, we've also included the current members, and when you go to the last page of the current members, you will see demographic information that also includes the proposed additions to the committee, so you can see a breakdown around race, ethnicity, geography, and disability in terms of current members and these 4 additional members. More than happy to take questions.
Any comments, questions? All in favor of accepting these members?
Aye.
Opposed? All right. Send them our
Thank you.
Congratulations.
Thank you very much. We're very pleased to have a full committee at this point in time. Thank you so much. And our committee will be very pleased as well. They're a hard-working group. So getting into the next portion of our presentation, Stacy and I are here to talk about to give you an update on the health equity measure work that we're doing. And just wanted to point out that you did receive a presentation, I believe it was last month, from Sean Parkman, who provided a very thorough, I believe very thorough and sound analysis of the work and the vote and the outcome. But what we wanted to do was talk about what's happening next, which is really the most critical, I think, conversation. As you know, the health equity metric that we brought forward earlier was not voted affirmatively, so we are continuing. We are not deterred, and we're continuing to move forward with some other opportunities that have arrived at this point in time. So just for some background, though, this work has been actually various renditions of the health equity measure work and health disparity measure work, which are 2 separate things. We'll speak to that. They're related, however, there's some distinctions that we need to make around that. And most recently, the board said we really see the need for an incentivized health equity measure, and so that was work that a group formed to develop that measure, and that measure that we brought forward related to healthcare interpreters, certified and qualified healthcare interpreters, and the utilization in the healthcare and health delivery system. That measure was developed in collaboration with communities, to Dr. Santa's point. with communities that are most impacted, and to the point of our previous presentation around populations that are most impacted. So it was really critical, important to us that we were responding to the needs of the community when we talk about health equity measure. And I do want to say very, very briefly, and we'll talk more about this throughout the presentation, that we're not advancing, just so you know, the slides. Thank you, Stacy, for your attempts. But we're focused on a health equity measure as opposed to a health disparity measure. And sometimes those are conflated. And it's really important to note that when we talk about a disparity, we're not going to be able to address the disparities that exist around health outcomes until we're addressing the flaws and the deficits in the system. So from a health equity perspective, the measure that we brought forward was truly to reflect, truly to measure an intervention and a strategy that has proven to provide more culturally responsive care. And we know that culturally responsive care then will ultimately move the needle on those health disparities. But our focus is on health equity, on the structure of the system, on the flaws in the system, on the deficits of the system that are undermining the health of priority populations. That's a really important distinction to make. Ultimately, that will move the needle on health disparities, but we're really focused on the system and how we impact the system and how we impact the system for the health of all people in the state of Oregon. So that was our focus. So our work here was to really measure the quality of healthcare interpreter services that people are receiving in the health delivery system, and being sure that they were afforded the opportunity to have qualified and certified healthcare interpreters, which is not only part of the fabric of the work we're doing here, but also from a requirement, federal requirement from national origin perspective. It's a civil right. It is a civil right to receive your health information in your primary language, and that is not implemented to its fullest. And that's why we focused here. So the measure didn't pass, as you know, but the work continues, and we're continuing to move forward. So next slide, and I'll talk briefly about where we're headed. So since we met with you last, we have had a major development that we're very pleased about, and that is the fact that we have been able to integrate the requirements of the health equity measure that did not pass into the CCO 2.0 contract. And so contractors, as you can see on the slide, contractor, and therefore CCO, shall collect and report language access and interpreter services to OHA on a quarterly basis. They will also complete a self-assessment to collect and report their progress in those areas, and they will do that quarterly beginning in April. So this is an opportunity for us to get the baseline information that we were looking to get in that first year of the health equity incentivized metric, but we've got it now incorporated into the contract for accountability around this work.
Can I just jump in? So yeah. This really stemmed from the board's discussion last meeting around sort of number one priority would be getting a quality incentive metric with dollars tied behind it. Since the Health Plan Quality Metrics Committee didn't adopt that, what would be the other types of things that we could do? And so this was really the result of the board's direction for us to go back and take a look. So money not attached to it in the sense that same way the quality pool is, but two things. One, it starts, creates the expectation, and two, starts to collect the data, which is one of the flaws that the committee raised, or concerns that the committee raised, which was validity of the data and how's the data going to work. So this allows us to get the data flowing, so then hopefully we can address that concern as if they take this particular measure back up in the future.
Thank you, Jeremy.
I don't want to get into the weeds, but the language as I see it collects the numerator. I don't know if it collects the denominator, because that's the issue that came up, because it was a rate, and my sense was the concerns were more about the denominator than the numerator. So
We will get into that. Thank you. Thank you for that observation. We appreciate it very much. And before I turn it over to Stacy, I just wanted to, when we talk about next steps, we are really doubling down on this measure. We feel like there was so much intentional and good work done that as we move forward, we will be doing work for this work to be part of the incentivized pool of measures. And for a variety of reasons, first of all, like we said, we did work, we had the best and brightest on this work. It was also work, very importantly, once again to Dr. Santa's point, that it was community-based. When we did our CCO 2.0 community engagement work, we were hearing over and over again from the community in all reaches of the state, all geographic locations, that people were not always getting qualified healthcare interpreter services. So we were responding to the community with this. This is critical to health equity, as I spoke to earlier, to address deficits and flaws in the system. So that's another reason. And the vote was close, 5-4. So it says to me this is a very salient measure. We need to do some additional work, as Dr. Santa pointed out, and Stacy will talk to more specifically what some of those next steps will be regarding the measure work.
Thank you. Thank you, Leanne. Thank you, Leanne. I'm sure it's me. So I'm just going to talk a little bit about next steps. As Leanne said, we really are trying to set the conditions, put the conditions into place so that this metric could be selected, has a higher likelihood of being selected the next time it goes in front of Health Plan Quality Metrics Committee. And the ways that we're doing that are what I'm going to be talking about. So to Dr. Santa's point, he's right that one of the concerns raised by the committee, the Health Plan Quality Metrics Committee, was that there was a disconnect, still would be, a disconnect between the numerator and denominator. So what we are addressing in asking the CCOs to submit their data quarterly is starting the flow of the numerator data, and then simultaneously OHA will be working to find one or two CCOs that's willing to work with us on the denominator issue. And the thing that I think is important to know about the numerator and the denominator is, although kind of technically they're coming from different places, the reality is that we can make them match. We do have person-level data, believe it or not, at OHA on people who receive Medicaid services. So we will be able to work with CCOs on the denominator to ensure that the denominator is accurate to what they believe should be accurate. So consequently, the numerator can be a subset of the denominator, which is always what you want when you create a rate. So this work that's up here on the slide right now will happen between now, obviously we've actually passed beyond July, so we've started some of this already. So through the end of this year, we'll continue to work with purpose and in partnership with communities who are most likely to be impacted by the measure. We'll also continue to have conversations with the committees as we move forward with our work to keep them abreast of any progress that we're making, any potential hangups that we're facing, and how we intend to address them. And in that way, they will have this information in front of them on a more consistent basis. I think one of the challenges we had with the metric, the way that it was developed last time, and this started before I started, but I believe we started the committee, the Health Equity Metric Work Group, started the work in October of 2018, and then the first vote, I believe, happened in March. with Health Plan Quality Metrics Committee. So we really didn't have a lot of interaction with them along the way to let them know what was happening. I mean, we certainly did our best, but sometimes it takes a while to work through all of the questions. So we intend to continue to have those conversations. And then this last point, I think, is a really important one because you guys have provided guidance or will provide guidance to HPQMC regarding the health equity metric adoption. And importantly also, there really are two parts to that. One, it's encouraging an adoption of a health equity metric specifically, but then secondarily and very importantly is adoption of a framework that allows more experimental metrics to be selected by the committee. And I want to let you know that OHA has been in conversations with an organization called State Health and Value Strategies. It's an RWJF funded organization that's out of Princeton. As I understand it, they contacted the governor's office and said, you know, we're really interested in the transformation work that's happening in the state of Oregon. We'd love to be involved and provide some technical assistance in any way that makes sense. And so internally to OHA, above my level, conversations occurred and they talked about different potential bodies of work, and in the end this was the one that we decided to move forward with this group, State Health and Value Strategies. So we had a conversation with them last Thursday I think. We still haven't heard whether they will be supporting this project, and it would be in-kind technical assistance support, but what we put forward is actually assistance helping to create the framework for selection of metrics that are, you know, outside of kind of the norm, that don't maybe have the evidence behind them. So we're really hoping that works. I think it'll be very valuable because we would have somebody helping us who's not part of the system. So it seems like you want to say
yeah, I was just going to add on. Well, I don't know that it necessarily makes us feel good because we've got a long ways to go and are way behind the curve in terms of advancing health equity generally as a state and country. I will say I've had a number of conversations with national organizations that have been tracking this work over the last year in Oregon because they have said we are actually sort of out ahead of some other states in terms of challenges that we're running into. And so there's several other states that are on the verge of wanting to pick up health equity measures and they have said they are going to run into the same issues we have: data quality, trying to define measures that don't come from a nationally accepted data set. So the good news out of that is that, you know, we're not alone and that folks are starting to reach out to say, hey, how can we help support you, because you guys are kind of trailblazing here and other states are going to be looking to. So again, you know, we're years behind where we like to be, but we are sort of leading the pack from a couple organizations I've talked to.
Thank you for that context, Jeremy. So after December, which it's usually around this time of year that I say to my family and friends in a totally panicked way, oh my goodness, Christmas is like around the corner. So no, I'm telling you, I'm completely freaked out. Christmas is around the corner, and the other holidays that happen in December, and will quickly be in 2020, which is a year that we'll really be able to see what's happening. That's a pun. Anyway, so in 2020, yeah, you just got it. In 2020, we will start getting the first flow of data for the numerator from the CCOs. The timing on this it's going to be a little tight, but we're going to do the best we can to ensure that the HPQMC measure selection timeline can accommodate the consideration of this particular metric. And again, hopefully that's through continued discussions with them. And then in 2021, hopefully, we will start collecting data and measuring this as an incentive metric if it passes through all the hurdles. But the other thing that we have a lot more control over that we can do is releasing a report based on the data that we will be collecting from the CCOs and also the denominator data and the work that we've done on that. That we're calling a state of equity report. It doesn't have to be called that necessarily, but we would specifically detail the language access service. So this is kind of akin to, you know, what Jeremy talked about earlier today. Even if a particular metric isn't selected as an incentive metric, we still highlight it in our CCO metrics report, and we would be doing the same thing through this mechanism. And with that,
I will just add that the State of Equity report is a report that the Office of Equity and Inclusion, we released 2 reports several years ago, and we've been determining what's going to be the next best way to focus that work rather than just jumping in and doing it annually. And so this represents a sort of intersection of a want and a need at this point in time. So that's part of the reason why right now that's how we're speaking to it around State of Equity report, but it could take a different shape or form. Questions?
John?
And just keep in mind, we've talked about a more global equity measurement. So how would this equity measurement be applied to Medicare or to commercial, given that we could have a statewide cost cap, and you would like to monitor quality and equity. And it would be nice to the degree you could that this work, as you move along with it, think about, could Medicare Advantage plans or Medicare collect this data, commercial, et cetera. But the only thing I disagree is that, well, there are a lot of meetings with equity on the agenda, a lot of meetings, and it was, I think, hard on everybody to hear at the very last one that these technical concerns came up, and it happens. Sorry.
I think that's a really good question about whether we could globalize or create a measure that could be used across all the lines of business. I think the challenge that we would have is the information that we have for CCOs pertaining to whether a person needs a healthcare interpreter comes from the enrollment process, and we don't have a comparable source of data for Medicaid or for commercial plans. So
Medicare, you mean?
Sorry, Medicare, thank you. So we'd have to somehow bridge that gap. I think we'd have to think about that.
I'm just going to add on 889 and on the benchmarks. So the 3 other states that have created a benchmark program, none of them took up quality. Well, I think Delaware, Rhode Island maybe have loosely did, but not probably to the same degree that we will in Oregon. So we'll be blazing trail there in terms of what do we want quality to look like in terms of cost benchmark. The bill does call for coordination with the Health and Quality Metrics Committee. So again, trying to keep that connection. Part of the reason that the implementation committee was set up under the Health Policy Board to try to keep these things connected. But some conversations with some experts we've talked with, they've said, if you're thinking about value-based payments or you're thinking about cost benchmark, these might not be the right sets of quality metrics. Generally, you might be looking at things like more people getting denials of access to care, and those aren't the types of measures we have. So all that to say, it's on our minds. I think we've got more work to do to figure out where the benchmark committee goes, and there may be additional new types of measures that we need to develop that come out of that process.
Stacy, you're correct. Christmas is right around the corner. And 2021 is going to be here soon. And so this process obviously has taken longer than we had hoped it would take. And so I'm just wanting to make sure that the committee thinks about what's next. So what will you have teed up? Because obviously it's going to take a couple of years to work on that next thing. And so where do you go next and for that next measurement? Because I think it's important to keep the ball rolling.
I think that's a very good point. I'm assuming you don't need an answer right now, but we will come back and talk about that when we have a better sense of that.
In terms of this new measure, I think I don't want to at all minimize the importance of providing interpreter services. You know, it has to be done well, it has to be done right, and John's brought up the numerator and denominator issue, which is important. So that absolutely has to be done. I also aspire to have an equity measure that addresses inequities in people whose primary English language is English. Because some of the greatest health disparities and inequities we have is in English, people whose primary language is English. African American communities, economically marginalized communities, urban, rural. I'm not minimizing the importance of providing healthcare in the appropriate language with the culturally appropriate interpreter. But it misses a whole giant area of inequity that I think we need to figure out how to wrap our arms around and deal with.
Agreed. You're speaking to the choir on this one, especially as a member of the African American community myself. And we've got to start someplace. And when we have a specific, we're hearing specific examples of how language access is not working, and we're hearing